Okay, thank you. So my case is case number 35. It was a 67-year-old lady with a 5-centimeter tumor in her kidney. So she underwent radical nephrectomy, and this is what we got here. So here is the normal kidney parenchyma infiltrated by this dark staining, and already from above here, pretty cellular looking tumor. And when you go to higher power, without much looking around, you can tell this is a high-grade malignant neoplasm. There was a lot of mitosis, atypical mitosis. There were also areas of necrosis. And otherwise, morphologically, in some areas, it had these kind of interesting, let's say, rosette-like areas or ribbons. And on higher power, you can see this clear cell, somewhat clear cell cytoplasm. So I think this is quite obvious diagnosis, right? Everybody knows what this is. Yeah, of course not. This is like a very rare morphological variant of a very rare tumor. It's impossible to diagnose based on morphology. I apologize for this case, but I needed a case with enough tissue to get to the diagnosis and to get to the topic. So anyway, it's from 2013, and back then it was worked up, and there was focal cytokeratin staining, was very focal, and multifocal strong PAX8 nuclear positivity, but everything else was negative. CD99 is 100, desmin, and some 20 more stains were completely negative. So in 2013, EWSR1 FISH was done, it was positive, and back then it was signed out as Ewing-like sarcoma, which I think is as good of a diagnosis as you could make back then. But I stumbled upon this case in the registry. I thought it looks interesting, so we did RNA sequencing and found EWSR1 POU5F1 fusion. So this is consistent with either, you can call it malignant myoepithelioma or myoepithelial carcinoma. When I say myoepithelial carcinoma for this tumor, it kind of tears my ears because it's complete nonsense. It's not any type of carcinoma. It's fusion-associated sarcoma and has nothing to do with carcinomas. So actually, since I started to do soft tissue pathology, I never really, for many years, I didn't comprehend the chapter of myoepithelial tumors. It seemed very confusing to me. And I remember my father telling me that it's just a mixed bag of tumors, very heterogeneous group, and we always talked about working on this topic and kind of do some research in this area. And so finally I got this with the help of many other people, as I'll get to it in the next few slides. So let's start just with the basic background, what we know right now. So the WHO chapter in the soft tissue book is called Mixed Tumors and Myoepitheliomas of Soft Tissue. It's again a very heterogeneous group of rare neoplasms, and the first concept, I mean, the tumors have been published for many years in the 20th century, but the first really kind of applicable concept, the first morphological and immunohistochemical criteria were introduced in 1997 by Drs. Kilpatrick and Fletcher. So the group based on the WHO classification currently encompasses mixed tumors, myoepitheliomas, and again, unfortunate name, myoepithelial carcinomas. So if you look at the diagnostic criteria, this is basically a citation from the WHO. You can have trabecular, reticular, nested, and/or solid growth of variable spindled or epithelioid cells with frequent myxoid or ionized stroma. So basically, almost any tumor in human pathology can fit into this definition. Mixed tumors, in addition, show ductal differentiation. So mixed tumors can have epithelial elements in the morphological picture. The malignant variety shows increased cytological atypia and usually also mitotic activity. Immunohistochemically, there is a positivity for so-called myoepithelial markers, which means you should have either EMA and/or keratin positivity coupled with either S100 and/or SOX10 and/or GFAP positivity. However, we know from recent years from studies based on molecular diagnostics where the tumors were defined by molecular the expression is highly variable. Some tumors with the fusions which are compatible with myoepithelial tumors can be completely negative for all these markers. Some can be positive only for EMA and negative for everything else. Some can be only positive for S100 and negative for everything else, and so on. In addition, there is a subset of myoepithelial tumors which shows loss of expression of SMARCB1. So it adds another complexity, another heterogeneity. And I will not be speaking about these tumors anymore with SMARCB1 deficiency, but they are again seem to be different tumors. So by molecular, you can see rearrangements of either EWSR1 or FAS. These genes are kind of, you know, from other tumors. They can alternate. They can create the same tumors. And these two genes can be fused with multiple different fusion partners, as I'll show you. Or some tumors, specifically the mixed tumors, can have PLAG1 or much more rarely HNG-A2 rearrangements. So again, you have basically two groups with completely different molecular. The PLAG1 and HNG-A2 gene is in a completely different signaling pathway than EWSR1 and FAS genes. In 2003, the first definition of prognostically relevant features was defined by Dr. Hornick and Fletcher. So tumors with no or very mild cytologic atypia were classified as benign myoepithelioma or mixed tumors, and indeed they, on long-term follow-up, some cases roughly one-fifth recurred but non-metastasized. Whereas the tumors which were defined as malignant, that means tumors with moderate to severe atypia, metastasized in 1/3 of cases. Surprisingly, this very simple definition kind of works pretty well until today. And then the first molecular papers started to come up. The first paper, which basically described the first molecular alteration in myoepithelioma, was this one from 2008, EWSR1 PBX1 fusion, then EWSR1 ZNF444 fusion was described, and the first systematic study of myoepithelial tumors was done by Dr. Fletcher and Antonescu. This beautiful paper, they described EWSR1 POU5A1, the same fusion we saw in our index case. They also found a bunch of cases with PBX1 fusion, one case with ZNF444. And very importantly, already in their paper, they noticed that the myoepithelial tumors which were negative for EWSR1 rearrangements were more often benign, they were more often cutaneous or superficially located. And all of them had the ductal or glandular differentiation. So they already alluded this will be something different. And indeed, after a few years, or like next year basically, two papers from Dr. Fletcher and Antonescu came out detecting PLAG1 gene rearrangements in these superficial, basically skin-located or dermal-located tumors. Then another papers describing different fusions of EWSR1 or FAS genes with various fusion partners such as KLF17, KLF15, PBX3 fusions, and also as kind of like a distinct another distinct subset with SS18 POU5A1 fusion came out. In 2020, this is probably the best right now available paper on myoepithelial tumors. Dr. Antonescu and colleagues collected this pretty large series of molecularly confirmed myoepithelial tumors, and they kind of studied them based on their specific fusion. They found out that the cases with EWSR1 POU5A1 fusion are, in most cases, not all cases, but most cases, have this kind of nested epithelioid morphology with clear cell cytoplasm. So it's different from the case I showed you, but it's a rare variant. It's kind of on a spectrum, I'll get to it. But most cases show this morphology. The cases with PBX1 or PBX3 fusions are more often benign and are associated with bland spindle cell and sclerotic morphology. In the skin, we call these tumors syncytial myoepitheliomas. Again, I'll get to it back again. The tumors with FAS or EWSR1 KLF17 fusions were associated with chordoma-like, or sometimes called parachordoma morphology, so tumors resembling chordoma but located outside of the axial skeleton in soft tissues. They have KLF17 fusions. In the last 2 years, these very nice methylation studies came out, and hopefully you can see, I mean, most studies were focused more on skin adnexal tumors, but they already included also some soft tissue EWSR1 FAS rearranged myoepithelial tumors. And here you can see KLF17, POU5F1, PBX1, PBX3, each forms a different cluster. And if you look here, the yellow dots are apocrine mixed tumors of the skin with PLAG1 fusions. And they cluster in the same area as salivary gland, myoepithelial neoplasms with PLAG1 rearrangements, but they are completely different from the EWSR1 FUS rearranged subtypes. The same here, this is somewhat smaller methylation analysis, but you can see PLAG1 rearranged cutaneous and salivary gland neoplasms roughly pretty much close to each other. The KLF17 or FUS KLF17 and EWSR1, PBX1, PBX3 completely separate clusters. So we decided to focus on this in a more comprehensive way to collect as many cases as possible. So we collected overall 56 cases of fusion-positive myoepithelial tumors, which was possible thanks to very generous help of Dr. Antonescu. She contributed roughly 1/3 of the cases, and we are working on this with Josephine Dermovan, and also you see a bunch of other fantastic soft tissue pathologists contribute either cases or expertise or both. So this is the study set we collected. 16 cases of POU5F1, myoepithelial tumors, and a bunch of other fusion subtypes. With, those are all rearranged with EWSR1 or FUS, and then 15 cases with PLAG1 fusions with various fusion partners. Here it doesn't really matter. All that matters is PLAG1 gene. The partner doesn't matter in this subset. And we perform methylation analysis. So we have methylation data for 43 out of 56 cases. We also got some external data from other studies or other sources. And this is our methylation results. Basically, this is the UMAP plot where you kind of graphically visualize the differences in epigenetic profiles. Here in the middle, the purple area, these are soft tissue myoepithelial tumors with EWSR1 and FUS rearrangements. Then you have here a bunch of other soft tissue tumors, sclerosing epithelial fibrosarcoma, NFAT-C2 sarcoma. Notice it's right in the middle of the myoepithelial group, I'll get back to it. Czech sarcomas and so on. But again, here, PLAG1 rearranged cutaneous, mixed tumors, cluster in the same area as the salivary gland, PLAG1 and HMGA2 rearranged tumors, completely separate from the soft tissue myoepithelial tumor. So it's a completely different tumor. Now imagine you kind of zoom in, you go on from 4x to 40x on your microscope, and we zoom in into this area. And we break down the myoepithelial tumors, this purple cluster, we break it down based on the fusion partners. And you can see that although they are all close to each other, they still form kind of distinct subclusters. So if you have myoepithelial tumors with POU5F1 here in purple, PBX1, PBX3 with green and blue right here, KLF15 tumors right here. So they're close to each other, but still kind of distinctly different. What is interesting also, EWSR1 or FUS and NFAT-C2 rearranged sarcomas, which are currently classified in the small round cell sarcoma category, along with Ewing sarcoma and Czech sarcoma, they land right in the middle of the myoepithelial methylation cluster, which is interesting because if you look at the morphology, they actually have myoepithelial-like morphology. If something looks like a myoepithelial tumor, it's this picture right here, and this is NFAT-C2 sarcoma. Their problem is that they don't stain with S100 and cytokeratins, so their immunophenotype didn't let them to be classified as myoepithelial tumor. But otherwise, epigenetic profile, EWSR1 rearrangements, and the morphology kind of is supportive of classifying them as myoepithelial-like neoplasm. Also, many cases are EMA positive, at least. Okay, this is basically a different visualization of the methylation data with unsupervised hierarchical clustering. And again, you can see PLAG1 skin tumors clustering here with salivary gland tumors, with PLAG1 fusions completely at the other side than the EWSR1 or FUS neoplasms. Again, NFAT-C2 sarcomas, right in the middle of the myoepithelial group. Okay, so then we did in-depth literature review and pooled analysis. We were basically searching the literature for cases with molecular confirmation, cases which had either EWSR1 or FUS fusions with all the various fusion partners which are recognized to be associated with myoepithelial tumors, or for tumors with PLAG1 fusions. Overall, we found 128 cases in the literature, so when we pulled it together with our cases, overall we had almost 200 of cases of molecularly confirmed myoepithelial tumors. And then we worked on this data to extract the salient features of each subgroup. So the PLAG1 rearranged skin tumors, basically, they have partially overlapping morphological and immunohistochemical features with the soft tissue EWSR1 or FUS. Myoepithelial tumors, on closer look, you can basically very easily say they are completely distinct based on their clinical pathological features. So these tumors basically always occur in adults. There was not a single case with molecular confirmation in people under 18 years of age. There are more in the older people. 53 years is the median. They are more common in females. And they are always superficial. In dermis or subcutaneous, no case has been ever described in bone, no case has been described in deep soft tissues, no case with molecular confirmation. They have a very distinct, strong predilection for acrocytes and head and neck, for whatever reason, and the vast majority is benign. Only 1 out of 12 cases with molecular confirmation metastasized after multiple local recurrences. Morphologically, they are very similar to myoepithelial tumors of salivary glands. They are generally very well circumscribed. They are in dermis or subcutaneous, and they are composed of sheets of epithelioid or plasmacytoid cells with brightly eosinophilic cytoplasm, and they often have chondroa or chondromyxoid stroma. There is usually no or minimal atypia, very rare mitotic activity, and usually you can see at least small areas with ductal differentiation. Cases that have a lot of ductal differentiation or a lot of epithelial structures, they are usually called apocrine mixed tumors. When there's very few of these ductal structures, they are sometimes called cutaneous myoepitheliomas, again creating a confusion. So regarding molecular, the vast majority has PLAG1 fusions. Rarely you can have alternative HMGA2 fusions. HMGA2 gene is in the same pathway, so it makes sense. By immunohistochemistry, when you look at, this is our recent study on these tumors, 100% of cases diffused S100 and SOX10 and AE1, AE3 positive. EMA a little bit variable, B63 often at least focally positive. So that's the PLAG1 group, always in the skin, always, or almost always ductal differentiation, almost always benign. Then we go to EWSR1, PBX1 or PBX3 tumors, overall 65 cases with molecular confirmation. Regarding clinical features, they are mostly, the vast majority is in adult patients, median age is 35 years. And the skin examples, which are by far the most common, and they are most likely highly underreported. It's a relatively common tumor. I see it 3-4 times a year. They're so relatively common that they are not reported anymore because it's not interesting. So they are mostly in the dermis and almost always on the extremities. Over 20 cases has been described in bone as well, mostly in metaphysis or diaphysis of long bones. 5 cases in lungs and thoracic, or generally in thoracic cavity. In the skin, they are always benign. In the bone, most likely because they have more time to develop, because they are noticed later, they have been behaving somewhat more aggressively. And the same applies for thoracic cavity. And as I alluded to at the beginning, these tumors were first described, the skin tumors were described under the heading cutaneous syncytial myoepithelioma by Dr. Fletcher. They were described based on their morphology and immunophenotype. It's very distinct, and only later the molecular background has been defined. EWSR1 PBX3 fusions are typical, much less common are PBX1 fusions. And tumors with identical fusion and somewhat similar morphology in most cases have been recently described, as I mentioned, in bone and in the thoracic cavity. So the vast majority has been classified as benign. Those that look benign, they always have this so-called syncytial morphology. I'll show what I mean by saying syncytial morphology. And the rest are usually, they usually have some atypia, and they usually present as ovoid or spindle cell sarcoma. with or without these low-grade syncytial areas at the periphery. Most cases are S100 and EMA positive. Cytokeratins are much more variable, usually negative. All cases are SOX10 negative. Mostly PBX3 fusion, PBX1 much less common. So here is on the left-hand side, you can see the syncytial morphology. This is the one you see most, basically in all cutaneous cases. Syncytial basically means that you cannot tell the individual cells apart, they kind of merge together. You can see the cell borders very well. And they have kind of like histiocytoid nuclear features, very low grade. And what is very helpful is actually this perivascular lymphocytic infiltrate, which is almost always present. The cases in bone and thorax which were more aggressive or had more atypia looked like this, just nondescript spindle cell tumor or spindle cell sarcoma, but again, sometimes on the periphery you can see the low-grade areas, so there's a possibility for kind of like morphological progression. Regarding the EWSR1 FUS BOU5F1 subgroups, there's 32 cases with molecular confirmation with a broad age range, but generally young adults. Typically subcutaneous or deep soft tissues, 16% in the bone. Again, just to tell the nonsense, how can you have a myoepithelial tumor in the bone? Where do you get the myoepithelial structures in bone? It's nonsense. So then again, there's in this subgroup you have a strong relation for extremities. Less commonly you can see it in the trunk or visceral locations. So far no case in the head and neck soft tissues. And now we're getting to cases or the subgroups which are much more aggressive, including the BOU5F1 group. 8 out of 13 cases metastasized, despite quite short follow-up. By morphology, thanks to more than 30 cases being reported, we can already see the morphological spectrum. You can see low-grade cases, which are kind of bland fibrotic, to something in between, which are tumors with moderate cellularity, moderate atypia, and this is the classical example. Nested clear cell morphology. This is the most common one you see. And then we have a few cases with this high-grade undifferentiated round cell basically morphology. That's the same morphology we saw in my index case. Overall, almost all cases had malignant morphology, so this benign, low-grade part of the spectrum seems to be quite rare. Okay, regarding the immunohistochemical features, all these molecular subtypes with EWSR1 or FUS rearrangements don't have major differences in the immunohistochemical or in the expression of myoepithelial markers based on immunohistochemistry. The main differences are usually with regard to the frequency of expression of SOX10. Some cases are always SOX10 positive, some are always negative, some are variable. But again, it shows that these tumors are different. As I mentioned before, there is a group of even more rare SS18 POU5F1 tumors, which seem to be different, again, because they are always high grade, always very aggressive. 5 out of 6 cases metastasized. The KLF17 subtype, I'll just go very briefly now. Again, deep soft tissues, sometimes in the bone. 3 out of 7 cases metastasized. Only 1/3 of cases had malignant morphology, so they seem to be a little bit more commonly benign. And this is the typical morphology. This is the so-called parachordoma morphology or chordoma-like morphology, but always brachyury negative, of course. KLF17 subgroup, just mentioned here, almost all cases in infants. So there's again distinct clinical difference. These tumors are affecting infants or young children. Almost always very aggressive. Again, quite consistent morphology, this myxoid stroma with high-grade small round cell morphology. Very little is known about this subgroup. Only 4 cases have been described, or all 4 had malignant morphology. Never mind. And my last slide. So, how about the nomenclature? The PLAG1 rearranged apocrine mixed tumors or cutaneous myoepitheliomas, this is how they are called now. They are always superficial, they are intimately associated with apocrine sweat glands, so they have close association with the myoepithelial structures, with normal myoepithelial structures. They also have consistent myoepithelial immunophenotype, and they have morphological and genetic overlap with salivary gland myoepithelial tumors. So to us this seems to be the true myoepithelioma of skin and sometimes soft tissues if they go into subcutaneous. However, in contrast, the cases I've been talking about with EWSR1 or FUS fusions, whatever the fusion partner, these tumors are typically in soft tissues, either subcutaneous or deep soft tissues in the muscle, or in bone, or in various visceral locations. There is no association with normal myoepithelial structures. They have much less consistent myoepithelial immunophenotype. Sometimes all the myoepithelial markers are negative. So it doesn't make sense to us to call these tumors myoepitheliomas. The problem is also, as I mentioned already, the malignant cases are routinely called myoepithelial carcinomas, although these are just fusion-associated sarcoma. So this might lead to quite serious, inappropriate treatment. So we would suggest, or we will suggest, that these tumors with EWSR1 FUS rearrangements will be called, based on their fusion, EWSR1 POU5F1 rearranged myoepithelial-like neoplasm, to kind of keep the myoepithelial word there, but make it clear that this is not a carcinoma or epithelial tumor. So here's just last slide to kind of sum up. Whoever wants to read through it can, and I'm happy to take questions.
Thank you very much. Next speaker will be going to be David Suster. Please.
Okay, we'll try to go quick to catch up a bit. This is a pretty interesting case. It's not actually a tumor. It's just like a weird little pitfall and just like a curiosity. So it'll just be a fun little presentation. I think it's also case 36. And the other good news is there's like no new fusions to learn. So we'll just go through it. Okay, so this was a 54-year-old male. Oops, sorry. 54-year-old male who presented with abdominal pain, weight loss, failure to gain weight, and cachexia. You can see the BMI up there. And so the patient underwent colonoscopy. They found the mass and imaging. They did CT abdomen, pelvis, and saw this tumor in the small bowel, looked like adenocarcinoma or colon cancer. Did a biopsy of the tumor in the bowel, came back as just a standard adenocarcinoma. So they set the patient up for a resection, and he had the small bowel removed. And my residents didn't photograph this grossly, but the gross wouldn't really help you here. So here's a representative image from the resection, and it is a very classic, colorectal type adenocarcinoma, and this is just to show what the main finding in the patient, but this obviously not presenting a case of colorectal adenocarcinoma, just conventional type, although that can get complicated too. The interesting finding here was sort of in the submucosa and the sort of pericolonic soft tissues, where the person who received this case and was signing it out found these unusual little sort of like myxoid nodules. Some of them were a little inflammatory, and you can see what this looks like on slightly higher power. So you have this kind of like, almost a little myxoid area and these small little vacuolated cells that maybe look like fat. But the person who was signing this out immediately got concerned that this could be a signet ring cell component, to this colonic type adenocarcinoma. Excuse me. Here it is on slightly higher power, So there's some pretty convincing signet ring cells. Some of them might actually even have a little bit of cytologic atypia. If you look up here, like this one here, pretty classic for signet ring cell. So got a little bit concerned, then started working this thing up. There was a whole battery of immunohistochemistry that was done on this. There was S100, was strongly diffusely positive, and then multiple different types of cytokeratins. I think I maybe glossed over this, but you see there's even a little bit of like subtle pigmentation in some of these cells, so they did melanoma markers, and we're spending a lot of money on this case, which probably not necessary, right? So here's the S100, highlights all of this, and remember adipose tissue, fat cells, S100 positive. Here's the cytokeratin, there's a little bit of the pigment that you can see, but it's basically dead negative. So once we convinced ourselves that this was not a signet ring cell component, we started wondering, what is this? We made essentially a diagnosis originally on the report that was descriptive. Then we started looking this up and ended up with this diagnosis here of pseudoneoplastic fat atrophy. Okay, so what is pseudoneoplastic fat atrophy? This is like a sort of normal physiologic process. It's been described in a few case reports if you go and you look out there, and in some textbooks, even some older textbooks. So you can see over here, that's some of the titles of these things: gelatinous transformation of bone marrow, dystrophic adipocytes, signet ring cell change in colonic subserosa, this type of thing. So people have encountered it before. And this is something that is in patients who are undergoing periods of starvation and malnutrition. It's this weird degenerative or atrophic change that affects the adipose tissue in these patients. And every now and then, as pathologists, we'll run into this almost exclusively incidentally. These are not mass-forming lesions or anything like that. And so they're essentially always occurring in hectic patients or otherwise ill patients, and have been described under all these different names, which leads to a little bit of confusion. But I've seen a couple of these things internally as consultations sent to me, and even one externally that got sent to me as a consultation, because people get worried that you could be dealing with some kind of lesion. The pathophysiology behind it is sort of complex. There's been some studies that have actually documented that there's like underlying molecular changes that occur in the fat tissue. They've kind of done this in mouse models, but you can see on this image here, where they took these mice and they started basically starving them and then analyzing their fatty tissue. You can see that it kind of starts looking a little bit like what we had on the right in the Max 16, whatever that is. So I started circulating images of this because I hadn't seen it before. I put it on Twitter. Some people answered on Twitter. And Dr. Waters from UCLA, Kevin Waters, actually presented a few at the evening specialty conference at USCAP 2 years ago. So I got in contact with them, and we actually put together this abstract. I know there's a lot of information on this, but the main takeaways from this that I want you to see is, number one, is every single patient was suffering from malnutrition over here. And look at the workups that were done on these cases, right? Some of that, I think, somewhere in here, I don't know where it is. Somewhere in here, somebody got DDIT3 fish, MDM2 fish. People were worried about liposarcoma and all this other stuff. And then you can see all of these suggested diagnoses, like a bunch of different ones. You can look up the presentation later. But this was presented at USCAP just recently. And it's just a curiosity. It's just an incidental finding. But if you've never run into it, it can trip you up and trigger this, immunohistochemical workup, or even worse, a molecular genetic workup on something that absolutely does not need it. So we looked at these. There's four women, 6 men. Every single patient was malnourished, as I mentioned, and they're all the cases we had occurred in the abdominal fat. I think it can happen in other places, but I guess if you just have a higher percentage of fat in that area, it's more likely to encounter it there. So it's characterized by these sort of variably sized nodules of atrophic, or some people call them dysplastic, pseudoneoplastic fat, that often have this signet ring cell appearance, or signet ring cell lipoblast-like appearance. And you get these myxoid stromal changes and this kind of like delicate vascular network that can raise a differential of things. And some of the proposed diagnoses that we got with these cases included signet ring cell carcinoma, liposarcoma, lipoblastoma, dystrophic fat degenerative changes, lipoblastoma-like tumor, and even myxoid liposarcoma. So it can trip people up. This is a few more examples from those cases in our study. So you can see on the top left, sometimes you can have kind of like a little nodule. It's myxoid, but if you look at it, it's like relatively well delineated. It's not like an infiltrative lesion. Sometimes in the top right panel, they can be a little bit more cellular. So you can get a little bit worried that you're dealing with a carcinoma. In the bottom two panels, sometimes they have this, a more prominent vascular network, or can be, kind of surrounding larger vessels. So you start getting worried, like, is this, a signet ring cell carcinoma invading the wall of a vessel? The differential, things that pop up in the differential, like I mentioned, sigmoid ring cell carcinoma, lipoblastoma, none of these are quite perfect for it. If you looked at a few cases, you'll pretty easily be able to start distinguishing these. But these are the things that we kind of saw that were popping up, in the diagnoses that were being submitted. So this is, an example from one of the cases that we had. You can see it's like, myxoid little nodule, has those signet ring cell or signet ring cell like lipoblasts or signet ring cells, whatever you want to interpret them as, and this kind of like delicate, thin capillary network that you sometimes see with a case such as this, which is a myxoid liposarcoma, right? So you can see how there's a little bit of overlap between these two things and how someone could theoretically be like, oh, what is this that I'm running into here? Especially if they don't have a lot of experience with this. And myxoid liposarcs can, this is a higher power, but can sometimes have that like signet ring cell-like morphology to the adipocyte. So just something to keep in mind. So with that, I'll wrap it up, and this case was short, but I just wanted to show that it's kind of this like unique curiosity if you run into it. All you really need to do is a cytokeratin, and if it's negative, you can get away with just calling it what it is once you've seen it. So those are the take-home points. It's almost always cachectic patients or malnourished patients. Can rarely, mimic signet ring cell carcinoma or even some mesenchymal neoplasms. And the literature is kind of all over the place. So, that paper is going to be published eventually, just as like a desktop reference. And we're just going to suggest the term pseudo-neoplastic fat atrophy for it. And the most important thing is just being able to recognize it so you don't waste a bunch of time and money, doing an extensive workup on these things. All right, and there's some references on some of the previous case reports that exist out there. So thank you very much.
Thank you, David. I wonder how many of those I have missed. Questions, some comments, please. It was a beautiful lesion.
Yep.
I'm sure it's not that uncommon.
I feel like now I've been seeing it a little bit more. Like,
You get acquainted.
now I look for them and then I see them and I'm like, oh yeah, people are probably just either ignoring this or every now and then getting stuck on them.
I get a little bit deja vu feeling. The first time I came here, it was a course of Michal gave about oddities. These things you probably see, but you never recognize until somebody point them out for you. It's great. Thanks a lot.
You're welcome.
Okay, so next speaker will be Dr. Perry. If I'm correct, yes. Welcome.
Hello everybody, so I have case number 37. I thought this would be an interesting case to share with you guys because to be honest, it's vicinity is probably more likely to initially go to a pathologist who doesn't site out soft tissue than somebody who's on a soft tissue service. So I thought it'd be applicable to multiple subspecialties within surgical pathology. So the patient is a 64-year-old who presented to the emergency department with leg swelling. It was found to have a cystic mass that was thought to be extending from the liver, measuring 21 centimeters in greatest dimension. Additionally, there was also a complex cystic mass that was associated with the proximal right ureter of the kidney, and that measured about 7.9 centimeters. Unfortunately, I apologize, I don't have imaging, but the initial biopsies were unsuccessful, so the patient underwent partial hepatectomy as well as a right radical nephrectomy. And so the morphology of the tumor was fairly unique in that you have these nested or sheet-like arrangement of these epithelial-like cells in the background of a dense fibrous stroma. And then when you go into higher power, these cells, again, they have an epithelial appearance with areas of clear cytoplasm, but still other areas where the cells have a more amphiphilic cytoplasm. And then there's also these areas of this microcystic architecture which have this eosinophilic material within. And then still other cystic formations of these epithelial-like cells have these papillary formations. Around the tumor, there's this lesional lymphoid aggregates, as well as some focal hemocytic deposition as well. So the immunoprofile was also just as perplexing in that these tumor cells were positive for cytokeratin. Some of them were exhibiting a paranuclear dot-like staining pattern. They were also positive for Oscar cytokeratin. Additionally, they were positive for ALK, as well as MUC4, and also showing some patchy staining for synaptophysin as well. So there's numerous other immunohistochemical stains performed as well that I didn't show, which includes focal inhibin, as well as CB10, and then they're negative for numerous stains, including chromogranin, glycogen-3, SAL4, SF1, PAX8, as well as NPM2 and numerous hematolymphoid markers. So sequencing was ultimately performed, and this tumor was found to have an EWSR1 CREM fusion. Consequently, it gave the diagnosis of an intra-abdominal EWSR1 CREM rearranged malignant epithelioid neoplasm. So we've already touched base with the some of the entity with a primary pulmonary myxoid sarcoma, which also has a similar fusion. CREM is part of the CREB family, which is a family of transcription factors that includes ATF1, CREB1, and CREM. These contain substantial homology in terms of the sequences, and basically these are in the nucleus and act as a promoter or enhancer of other target genes, and consequently can act as a proto-oncogene supporting tumor initiation, progression, and metastasis. So usually when I talk to my residents or trainees about the importance of morphology and how sequencing is not everything, a lot of times I'll start talking about the CREB family of associated fusion tumors, which seems to be ever growing. And it's a very remarkable, I think, family of tumors because they all share the same fusion yet have remarkably distinct morphology as well as clinical behavior. And it just goes to show you that morphology or histologic examination will still be relevant in the age of molecular diagnostics. So more recently there's been a few case series that define a distinctive novel entity of malignant epithelioid neoplasms with predilection for mesothelioid line cavities. One of the first series was by Arkadi and colleagues. And in this series, they again have the either a FUS CREM or EWSR CREB or ATF fusion. And these typically arose in areas in the abdominal cavity, including the mesocolon, the omentum, adnexal, or parapancreatic, among others, kidney as well. In terms of the behavior, they were quite aggressive with about 50% metastasizing. And these tumors exhibited distinct histologic features that really were not obvious or appreciated in these other previously described entities within the CREB family. And I've described this before, but just to reemphasize, these include a nested architecture with these lymphoid foci. Again, having those areas of cystic areas of architecture of the tumor, microcystic formations with the eosinophilic material, cells with clear cytoplasm or eosinophilic cytoplasm. And so those are the main histologic features, but then there's also some minor histologic features that can also be appreciated, such as some of the tumors can have like a round cell component or sometimes a spindle cell component. And then Abbas Agami, he also had a nice series of 2 cases which further discussed the immunohistochemistry of these tumors and the ability or the problem with these tumors to mimic other entities and create a lot of diagnostic confusion. And this includes these tumors being positive for not only epithelial markers such as AE1, AE3, and EMA, but also positive for WT1, ALK, MUC4, neuroendocrine markers, amongst others. So in terms of how these tumors behave, like I said before, they can be quite aggressive. In our particular patient, there's a likely there was residual and recurrent disease by imaging, and there's probably also a clinical suspicion right now of metastatic spread. And just to illustrate the complexity or diagnostic complexity of this tumor, there's multiple preliminary diagnoses before the molecular came back, including a renal cell carcinoma, a rhabdoid tumor. Cancer type ID was run, which predicted this to be a chondrosarcoma or a Ewing sarcoma. So I think there's a lot of space to have a healthy appreciation for this novel entity to prevent a misdiagnosis. And so more recently, there's been numerous other series of tumors with this epithelioid morphology that have an EWSR-CREB fusion that have really been published in the last 2 years in multiple anatomic sites. Now, don't really have time to go through all of those, but I thought I just would illustrate some of the critical entities in the differential diagnosis, just to illustrate some of the problems and things to look out for to initiate the appropriate workup and sequencing to make the appropriate diagnosis. So things that have come up in the differential diagnosis for these EWSR1 CREB fusion tumors are angiomatous fibrous sarcoma, epithelioid inflammatory myofibroblastic sarcoma, sclerosing epithelioid fibrosarcoma, as well as alk-rearranged renal cell carcinoma. So the first one I want to talk about is angiomatous fibrous sarcoma, which commonly these occur in the soft tissue of the extremities in children or young adults. However, parenchymal locations such as the lung can occur. These do share some histologic features with this new entity, such as a capsule with a lymphoid cuff, and these can also exhibit ALK expression. Unlike our entity of these malignant epithelioid neoplasm, these are angiomatous fibrous sarcomas, typically indolent with only a rare chance of metastasis. And in terms of the difference morphologically, as we know, angiomatous fibrous sarcoma, the cells typically exhibit more of a histiocytoid appearance, in which there's usually more ovoid or spindling-like morphology. Also, the cellular borders, I think, are less distinct in angiomatous fibrous sarcoma, as opposed to our tumor, our intra-abdominal malignant epithelioid tumor, where you have more of an overt epithelioid morphology in the cells. Next entity is epithelioid inflammatory myofibroblastic sarcoma, which is somewhat of a very inflammatory myofibroblastic tumor, but of course it's much, much more aggressive, hence the name epithelioid inflammatory myofibroblastic sarcoma. They have some similarities in terms of clinical presentation in that they can also present commonly in the abdomen and pelvis. These commonly occur in children in early adolescence, and again, these are much, much more aggressive than just your inflammatory myofibroblastic tumor. These are often associated with an ALK-RANBP2 fusion. So this is an illustration of epithelioid inflammatory myofibroblastic sarcoma, where you also have these epithelioid-like cells with a background inflammatory infiltrate, but the background inflammatory cells are usually composed at least of a prominent component of neutrophils as opposed to the lymphoid aggregates that we see in our tumor. These also have a much more prominent nucleoli that we see in our epithelioid tumor, in which the nuclei are less, the nucleoli are not as conspicuous. And the ALK staining pattern in inflammatory myofibroblastic sarcoma also has a characteristic staining pattern of either a paranuclear staining pattern or a paranuclear dot-like accentuation pattern. So the other entity that can come up is sclerosing epithelioid fibrosarcoma, which is an epithelioid-like sarcoma that's predisposed to the abdominal cavities and that can also exhibit peritoneal-like spread. This is an aggressive tumor with an increased metastatic rate, and most of us have encountered this at some point, where you see these epithelioid-like cells in the background of dense fibrosis with this crackling-like collagen pattern. The cells percolate, they typically have a compact chromatin structure. But again, you can have areas of more abundant cytoplasm which exhibit morphologic overlap with our epithelioid tumor with EWSR fusion. They both can stain for MUC4, so you have to be careful not to overinterpret the MUC4 in our tumor as being a sclerosing epithelioid fibrosarcoma. Of course, sequencing can be helpful in that sclerosing epithelioid fibrosarcoma most commonly exhibit EWSR1 CREB3L1 fusion. The last entity is an ALK-rearranged renal cell carcinoma. These can either have a VCL-ALK fusion or a non-VCL ALK fusion. The non-VCL ALK fusion can exhibit considerable architectural similarity to this tumor. And if you go back and look at the literature, this is one of the entities that often gets considered with respect to the differential diagnosis of EWSR-CREB epithelioid tumor. So the non-VCL ALK-rearranged renal cell carcinoma can exhibit combination of architecture, including solid or cribriform architecture. It can have pseudopapillary formation. So this is an example of an Alcrete range renal cell carcinoma from our archives, which you see this areas of solid and cystic architecture, with the cyst exhibiting this eosinophilic material. And there's also a paralesional lymphoid cuff. So again, you can appreciate very similar morphologic features, also staining for ALK. But unlike our tumor, these tumor cells are positive for PAX8, and of course sequencing is going to be the ultimate determinant in terms of the distinguishing between these two entities. So in conclusion, there's a rapidly growing spectrum of PREB1-associated fusion tumors with epithelial morphology. This includes fusions involving PREB1, ATF1, and PREM. The distinct morphologic features from previously much work remains to be done in understanding and classifying these tumors, and it's important that we have a high degree of suspicion when encountering an unusual epithelial-like tumor with an unusual immunoprofile that we appropriately sequence and consider this entity in the differential diagnosis. That's it. Thank you.
Thank you, Dr. Perry. Some time do we have for questions and comments?
Excuse me, has anybody encountered this? Anybody else?
We had one in the peritoneum, and there was a rather discussion about the case because the clinicians were thinking that was a mesothelioma.
Yes. Yeah, of course, I didn't get into it, but there have been mesotheliomas reported with the same fusion, and I think it's getting quite complex because there's different organ systems that also have this fusion, and so I didn't really want to get into it, but I think it's going to take time to figure out how much do we parse these out as individual entities versus how much do we lump these things together, and that's a whole other discussion. It'll probably take quite several decades probably. Thank you.
Yeah, just one comment, sorry.
Oh, sure.
We have one case of gastrointestinal, like a clear cell sarcoma, like tumor with this type of fusion, and it also has a SMARCA4 deficiency, which is sort of unusual, which gave the even more reptile morphology. So that's you asked if someone has something similar.
Yeah, importantly, these are negative for S100 and SOX10, but they can also have areas of rhabdoid morphology as well, in addition to areas of round cell and spindling. Gastrointestinal neuroendocrine tumors or clear cell sarcomas can show that fusion as well.
So it's similar in some aspects, but actually it's okay.
Okay, if we have no more questions, so thank you, Perry, and we welcome Michal and Michal back.
Thank you. I forgot to apologize before for going over time. I hope to make it up a little bit now. So this next case is a case in the skin of a 22-year-old girl who had a tumor on her thigh measuring 0.9 centimeters. You can see a tumor centered in the dermis, but growing, widely infiltrating the subcutis. If you look at the epidermis, there was nothing. It was completely normal. But right in the papillary dermis, or upper dermis, you could see infiltration with this clear cell neoplasm, which showed this nice permeating growth pattern in between the collagen bundles. And if you look on really high power, the clear cells are quite bland. There was really minimal atypia, no mitotic activity, and almost always this brightly or very prominent clear cytoplasm. Again, this nice pattern of permeation in between collagen fibers. The authors that describe this tumor call it checkerboard-like pattern of invasion or of infiltration. Otherwise, the tumor looks identical throughout, really. Some prominent nucleoli, but no mitosis, no atypia. Okay, so regarding the immunophenotype, you can wonder whether this is some weird melanocytic tumor, or is it a Pecoma, or some clear cell sarcoma. So we did S100, SOX10, both were negative, and we did other melanocytic markers. Tyrosinase was diffusely positive, HNB45, kind of weak, patchy. Again, this most characteristic morphological feature, this pattern of invasion in between the collagen bundles. And then we did sequencing, and we got the diagnosis of cutaneous tumor with actin-MITF fusion. Actually, the fusion is not with actin gene, but actin gene family. The specific fusions are either ACTB or ACTG1. They both belong into the actin gene family, and they are collectively described as actin-MITF fusions. So far, only 9 cases have been documented, almost all in this very nice paper by Dr. Chardier and John Hanna. We also have 2 cases in our registry. All 11 are in women with a pretty wide age range. They almost always are on the extremities. Only 1 case on the breast. So far, no local recurrence or metastasis have been documented, but the follow-up is fairly or very limited. So these tumors are currently classified in the chapter on melanocytic neoplasm, in melanocytoma group as MITF pathway activated melanocytic tumor. They are classified in this chapter along with similar tumors with similar fusion MITF CREM. Interestingly, there are another tumors with CRTC1 TRIM11 fusion, which look very similar. The molecular pathogenesis is very similar, but these tumors are, for whatever reason, classified in soft tissue tumor chapter along with dermal clear cell sarcoma. But actually, these 4 tumors, dermal clear cell sarcoma, CRTC1 TRIM11 rearranged cutaneous tumor, and these 2 MITF rearranged tumors are actually very similar looking, very similar pathogenesis, somewhat similar clinical features as well. So hopefully they'll be classified together in the next WHO. So whatever the fusion, ultimately this all leads to MITF gene overexpression. And MITF is part of the MIT TFE gene family alongside other genes such as TFE3 or TFEB, and serves as a key regulatory protein in the development of melanocytic lineage. It supports melanocyte survival and proliferation, and thus it leads to tumorigenesis. It also regulates the expression of the well-known melanocyte proteins such as HNB45 or melanine. So all these 3 tumors tend to involve the dermis with variable extension into the subcutis, and typically they lack an intraepidermal component which helps to distinguish them from true melanocytic tumors. They are all frequently HNB45 melanine positive, and they have variable S100 or SOX10 positivity based on the fusion subtype. I'll show it later in detail. All 3 have similar morphology and immunophenotype, and therefore they have similar differential diagnosis with clear cell sarcoma, Pecoma, of course melanoma, and also cellular blue nevus. So these 4 tumors always enter the differential for all 3 of them. Actually, the case I showed you is from 2009, and back then it was diagnosed as paraganglioma-like dermal melanocytic tumor. This is a paper from 2004, and indeed it includes tumors that look identical by morphology. So at least some of the tumors in this old paper are actually tumors with actin-MITF fusion. Recently, this paper, again from Dr. Hanna, came out. He was looking through the archive of Dr. Fletcher, and he was looking for Pecomas with MITF overexpression. He found 36 cases, and he did molecular analysis of these tumors. And two out of the 36 cases that looked like Pecoma had, again, actin-MITF fusion. So now, actually, this paper brought up the question whether these tumors are actually a subtype of Pecoma or whether they are different tumors. And that's to be, we need more data, more research on this. So regarding the other molecular subtype within this MITF pathway activated cutaneous tumors are CRTC1 TRIM11 cutaneous tumors. There is much more known about them. Again, this is tumor classified in the chapter on soft tissue tumors, but is very similar to these other two tumors. So we know quite a lot about these tumors because more than 50 cases have been reported already. There's a broad age range. Typically, these tumors are on the extremities or on the trunk. And the morphology here is the typical example, very well circumscribed, dermal-based, small tumor nodule, lacking intraepidermal component. Otherwise, the morphology is very similar to clear cell sarcoma, basically intersecting nests or bundles of atypical epithelioid or spindle cells with eosinophilic cytoplasm and prominent nucleolus. However, the mitotic activity is usually lower than you see in clear cell sarcoma. Another example, here by morphology, really, I think it's indistinguishable from clear cell sarcoma. Also by immunohistochemistry, it has the identical immunoprofile as clear cell sarcoma. All cases are diffusely SOX10 positive, most cases are S100 protein positive, and HNP45 and or melan A positive. Why this tumor is important to distinguish from clear cell sarcoma? It seems it's more indolent. 6 out of 38 cases with follow-up had adverse event, which is better than clear cell sarcoma. And only 7% had, 30% had lymph node metastasis, 7% had lung metastasis. This is the best paper on these tumors, describing 41 cases, again by Dr. Hanna, who is the godfather of this area of pathology. Very briefly, the last subgroup, tumors with MITF-CRAM fusion, only 3 cases reported. One is from our institution. 1 case was in adult women, 2 cases were in newborns, 2 cases on the scalp, and one out of the 3 cases recurred. So this is the case we published as a case report. So again, no intraepidermal or junctional component, only this, epidermal hyperplasia. And again, the morphology indistinguishable for me, at least morphologically, from clear cell sarcoma. These cases were often quite mitotically active. Our case had 11 mitotic figures per 10 high-power fields, atypical mitoses. So really, the only way to distinguish this from clear cell sarcoma is by molecular. The same immunoprofile. And if you would like to read more about these tumors, we published here with Tonia Kalnikova this review on changes in the WHO classification on mesenchymal tumors, or very, very recent, basically from last week, a review paper written by Thomas Brem with my little support in Advances in Anatomic Pathology about these tumors only. So thank you for your attention.
Thank you, Markku. You brought us back on the time scale, so we have time for questions and comments. Yeah, I mean, the expanding differential diagnosis of melanocytic tumor is getting difficult. I'm glad we have you around. So anybody want to comment or ask something about this interesting developmentations? If not, thank you again. And please, now I think we have Dr. Gross coming out.
Okay, so this is a 33-year-old female with without significant pathological history, and she presents with an increasingly painful arm mass. She states that this mass had been around for at least 6 or 7 years. At that time, it was a small lump. She describes, this documented, that 3 years ago she had a C-section. She discussed this with her surgeon, but she declined to have any imaging. And then now with this new enlarging mass, they did cross-sectional imaging. Okay, so in the CT, you can see that there's a mass in the upper arm, and there's a focus of matrix mineralization right there in the center, which looks like bone in the middle of it. On an MRI, it's dark on T1. This thing's kind of funny. And then on fat suppression sequences, it's with contrast, a lot of contrast, so it's a lot very vascular on the left, the satchel T1, and on the right, the T2 fat sat, which is a water sequence, so it looks biphasic. And again, in the coronal plane, again, there's a biphasic pattern here with a fat saturated plus contrast sequence on the left, and then a stir, which is also another water sequence on the right. So a core needle biopsy was performed at an outside institution. Apparently it was non-diagnostic. We never actually saw that material, but the patient ended up coming to Johns Hopkins for therapy, and so after waiting around forever to try and get this non-diagnostic biopsy, our surgeon just went ahead and did an open biopsy. And so again, this is an open biopsy. At low power, you see a biphasic pattern, which to me, it looks immediately like desmoplastic small round cell tumor with primitive blue cells and then this hypocellular desmoplastic appearing stroma. Another very low power photograph. Again, it really, to me, it looks like if this was in the abdomen, I'd say desmoplastic small cell tumor, maybe not even do any stains. Boom, get the case off my desk. At higher power, you get this very primitive appearing cells. On the left, you have this desmoplastic stroma, fine chromatin, but there really wasn't any mitotic activity that we saw in this open biopsy. Very fine chromatin, smooth nuclei, inconspicuous nucleoli, kind of grown in cords, nests, islands, and trabeculae. At higher power, again, very fine chromatins, very smoky, again, not any mitotic activity, and no necrosis on this sample. So by IHC, it had, I didn't know what this was, so did a bunch of stains. It had a little bit of 34, a little bit of STAT6, but it really didn't look like an SFT to me. Had some B-core, had a little weak CD99, and then negative for a ton of stuff. So I didn't know what it was, so I just made up some crappy diagnosis. Unusual mesenchymal tumor, uncertain malignant potential. I said I was going to do some molecular, but really what I wanted is for the surgeon to just remove this. Our fusion panel at Hopkins was negative. We did our DNA panel, which had a low TMB without significant copy number alterations. And we, at the time, since I knew this specimen was coming, we had had a little bit of tissue we had sent for cytogenetics, and the cells failed to grow. But we do have something called optical genome mapping. I'm not going to get too much into that if there's time left. I can talk about it later, but that's going to be pending. I did send, so our panel was negative, but I did send it to another institution, and they detected a CRTC1 SS18 fusion. So we'll talk more about that later. Fortunately, the patient did have surgery, upfront surgery, and here's the specimen. And one thing I forgot to mention on the radiology photos is that this thing is centered on the triceps tendon. So it's like straight up a soft tissue mass, centered on the triceps tendon, and like most soft tissue sarcomas, it has a pushing border of with a fibrous pseudocapsule. Here's another girl's photograph. Again, this is the fresh specimen. You can see in the center of the triceps tendon, fleshy, tan appearance to it, somewhat glistening. At low power, again, the surgical resection specimen looked a lot like the biopsy specimen, desmoplastic stroma, primitive round blue cells. You've seen here kind of grown in islands, tongues, cords, and groups. Here's that focus that we saw radiographically of bone. You can see it's lamellar bone. There's some lymphovascular invasion though at the top. Here, you can see it a little bit better. Let's see a picture here. There's some lymphovascular invasion in this specimen. And some of the areas are a little bit more clear. Now, I don't have photographs of this, but there was also a separate specimen, and I didn't make a big point of this on the radiology, but there was a separate specimen of a lymph node met. And so, by IHC, it had, still some kind of relatively non-specific staining. Now the GATA3, the Paxate was done because we already knew this had this fusion, and there was a little bit of literature on that. We'll talk about it in a second. It was negative for the SS18 SSX and the SSX C-terminus. Again, remember, this has an SS18 fusion. And then negative for those other things, including keratins. DNA NGS actually went back. Now we knew that it had this fusion, went back, and it does have a 1819 fusion by DNA. Initially we just said the copy number profile was negative, TP was negative, et cetera. And then their optical genome mapping, even though the karyotype failed, our optical genome mapping did show the 1819 fusion right there, SS18 and CRTC1. So the final diagnosis was an undifferentiated round cell sarcoma, extensive desmoplastic stroma, had this fusion, 9.5 centimeters, and then again there was a lymph node event. So what about this tumor? So on the left, there's the sentinel series of 2 cases by Alhal et al. Talking about this recurrent CRTC1 SS18 fusion. I think this was in 2018. And then there was one case report in IJSP in 2022 and talking about aberrant expression of ALK in this tumor. So there were 3 cases in the literature. So we went back and looked through our files. We had this case, searched back in our files at Hopkins, and we actually found 3 additional cases. So, and here's our publication just from last year of this tumor. Now we wanted to make it known to people that it really does have a lot of desmoplastic stroma, which certainly could be a pitfall, but could also be a clue. So our total of 6 cases, or the total world literature of 6 cases, our series of 3 patients is described here. There is a slight female predominance. It has a age range, including a pediatric patient that we found up to age 42, average age of 34, all were intramuscular. 2 of these patients underwent neoadjuvant chemotherapy without any response, and 4 had upfront surgical excision. Histologically, this is a uniform round epithelioid cells, moderate eosinophilic cytoplasm, getting grown in these tongues, nests, cords, sheets, similar to what I would describe to you as like desmoplastic small round cell tumor, or DSRCT-like. All desmoplastic stroma, at least focally. Again, the IHC can be non-specific, sure, positive for 99, there's a report of it having ALK, GATA3, cyclin D1, etc. But it is negative for the new synovial sarcoma antibodies. However, if you were to do FISH, that would be positive. Again, that could be a pitfall. Someone is thinking, like, oh, synovial sarcoma, and you get the FISH, oh, see, I was right. Wrong, it's not synovial sarcoma. Here are some pictures from our manuscript. Again, so these are of the 3 cases that we reported. Some of these I showed, but here are some additional examples. Again, you can see the desmoplastic stroma. Again, some of the additional photographs here. Primitive round cells, desmoplastic stroma, and a growing in cores and nests and tongues. Here's a molecular figure from our figure. 2 of the cases had the same fusion at the same breakpoint, one with this variant fusion breakpoint. So, as far as clinical follow-up is concerned, 2 of these patients experienced an elongated course, average age of 7 years prior to diagnosis. 2 of the patients underwent neoadjuvant chemotherapy, as mentioned, without any response. 2 of the patients developed METs. 1 patient with lung METs and a fatal outcome. Then the other patient at Hopkins had the local regional METs and had adjuvant chemo. I just checked it out before this talk. It's now been 16 months since her surgery, and they're basically following. There's a very small lymph nodes in her lungs. And 2 patients were NED, and 2 were lost to follow-up. But again, we need more data. So, and this was kind of mentioned multiple times throughout this talk, so I'm not going to talk too much about this, but SS18 now can be seen in a lot of different tumors that are not synovial sarcoma, including this paper here that Frederick Peterson and Michal just published of an SS18 POU5F sarcoma of the parotid gland. And then Michal just mentioned a lot of the CRTC1 fusions. So, here, and it was mentioned yesterday with the mucoepidermal carcinoma. So just know that there's a lot of CRTC1 fusions as well. So in summary, this case I think emphasizes the value of careful clinical radiographic morphologic ancillary studies. Some targeted panels can be negative, but you should still have a high index of suspicion and trust your instincts. And then finally, we are entering a rare age of esoteric soft tissue pathology, and so I really rely upon international collaborative efforts, and I think it's a very exciting time to be a bone and soft tissue pathologist. Any questions?
Thank you, Dr. Gross. Questions, comments? Right. I have nothing to comment. Thank you very much. And Dr. Perry is back for our second last case before the lectures take over. Come here.
Okay, so this is my second case. So this is a patient with an 18-year-old, sorry, this is an 18-year-old patient with a right upper quadrant abdominal pain. And it really did not have any significant past medical history. And on imaging was found to have this quite extensive mass that you can see here. Just bear with me, I'm getting the hang of this pointer. Oh, there we go. So, as you can see, that the mass isn't really that hard to see, but basically abutted the chest wall, as well as the pericardium. You can see here as well. So, in terms of the differential from a clinical and radiologic standpoint, it was pretty much a mediastinal type of differential, including lymphoma, a thymic lesion, germ cell tumor, some sort of weird thyroid mass, amongst other possibilities. Also, given that the close approximation with the chest wall, there's also considerations of whether or not this could be from a chest wall origin that was extending into the mediastinum as well. There was an initial neoplasia biopsy or initial biopsy that was performed, but it was non-diagnostic, and so the patient just ultimately underwent resection of the mass. So here on the resection specimen, it has quite a heterologous microscopic appearance, and so there's more bland areas with background myxoid stroma, where you have these mesenchymal cells floating around. And in this area, you also had mesenchymal cells forming these mucin-like pools. And then on the higher power, you can appreciate the mesenchymal cells exhibiting lipoblastic differentiation, where you see the vacuoles scalloping the nuclei, as lipoblast like to do. Then there's other areas where the adipocytes exhibit a little bit more maturity, where obvious adipocytic differentiation. And these were juxtaposed to higher areas of high-grade tumor that you see here, in which the tumor cells exhibited this sheet-like to streaming-like architecture, in which the tumor cells were obviously pleomorphic, exhibiting nuclear enlargement, irregularity, hyperchromasia. And within the higher grade component, there were still scattered lipoblasts present. The mass approached the rib, but did not really extend from the rib or the periosteum of the rib. So in terms of the immunohistochemistry, there's numerous studies done. It's negative for MBM2 as well as DDIT3 and a few other markers as well. Here's the DDIT3, which was negative. But in molecular findings exhibited almost a complete loss of heterozygosity by STIP microarray. Also lacked amplification in the 12q13 to 15 region, which would include MBM2 or CDK4. So the diagnosis would be consistent with a myxoid pleomorphic liposarcoma. So I thought I'd talk a little bit about this rare type of liposarcoma. It was recently recognized, or not really that recently, but recognized in the last edition of the WHO. It has a very unique clinical presentation in that it has a predisposition for children and young adults, with the mediastinum being the most common location by far. You can see case reports of this entity going, several decades back, but in terms of one of the case series that really started to flesh out the features and the terminology was Pathology and colleagues. They had a series of 82 cases of liposarcomas in young patients, and a subset of these included these pleomorphic myxoid liposarcomas, which you see here have again a predisposition for the mediastinum. In their series, the features essentially are reminiscent of what we see in our case, where you have these bland areas of myxoid stroma with these scattered lipoblast that are juxtaposed to higher grade tumor with pleomorphic cells. In addition, some of the features also include in the myxoid stroma branching capillary network, as well as fibrous septations and tumor necrosis in the higher grade areas. So in terms of the differential diagnosis of this, it's pretty much going to be the other malignant lipogenic tumors, which when you're looking at resections, really doesn't get too, crazy or complicated, by soft tissue standards, but when you're dealing with a limited core biopsy, it gets much more complex. And so I just wanted to go through some of these issues that you can come up with a differential in this entity. So the first one would be a myxoid liposarcoma. These typically arise in the soft tissue in the extremities, but the mediastinum has been a rare location of occurrence. These typically, unlike a myxoid pleomorphic liposarcoma, myxoid liposarcoma will transition to a higher grade component with typically exhibits round cell type features. And of course, myxoid liposarcoma has a characteristic translocation, which ultimately results either in a fusion of the FUS DDIT3 or EWSR DDIT3 genes. And so here you can see myxoid liposarcoma with bland myxoid stroma with mesenchymal cells and a capillary network and exhibiting scattered lipoblast. One clue that you're dealing with a myxoid pleomorphic liposarcoma, again, if you're dealing in a situation where you have a limited biopsy, is that myxoid pleomorphic liposarcoma will often have at least a few cells which exhibit more nuclear atypia than what you'll typically see in a myxoid liposarcoma. That being said, I have seen occasional myxoid liposarcomas which exhibit some unusual features. This was a myxoid liposarcoma like I had about a year ago, which had a round cell component, but did have this very focal area by almost these spindled cells with also increased nuclear atypia. Again, it was less than like 2 or 3% of the tumor, but this is an extremely rare phenomenon, so it's more very much the exception to the rule. But these areas did exhibit DDI2-3 expression and have a rearrangement. The next thing in the differential, the next entity in the differential, of course, would be a well-differentiated or dedifferentiated liposarcoma. And both of these entities can exhibit myxoid stroma, which can mimic myxoid pleomorphic liposarcoma. Of course, both of these entities are going to exhibit amplification of 12q13-15 region, which will contain several oncogenes, the most notorious being MDM2. And of course, we can all look for MDM2 gene amplification by FISH. So this is a well-differentiated liposarcoma with myxoid features, which can exhibit this branching capillary pattern that can mimic other lipogenic tumors such as myxoid pleomorphic liposarcoma. Of course, and then dedifferentiated liposarcoma can also exhibit myxoid features, which again would be in the differential diagnosis, but again would exhibit MDM2 gene amplification. Probably the most difficult one to differentiate is a pleomorphic liposarcoma. These typically occur in the extremities, but the mediastinum is a rare site of involvement. And these are characterized by a high-grade sarcoma with pleomorphic lipoblast. But unlike these other entities, other types of liposarcomas that we talked about before, they don't have a characteristic fusion or gene amplification that makes for a nice, neat ancillary study that you can do. Pleomorphic liposarcoma also can have multiple morphologies, which can sometimes make diagnosis a little bit difficult. The easiest one probably to diagnose of a pleomorphic liposarcoma is when you have a lipoblasts-rich morphology, which you can see here. We have numerous pleomorphic lipoblast. Sometimes you can have more of an epithelioid-like morphology, which can actually mimic a carcinoma, and sometimes these can actually be keratin positive, so these can be quite tricky, and with the lipoblasts or the characteristic lipoblasts can actually be quite focal. And then you can have a UPS, undifferentiated pleomorphic sarcoma, like pleomorphic sarcoma, in which the lipoblasts can be quite scant, and you can have substantial areas of the tumor which basically morphologically look like an undifferentiated pleomorphic sarcoma. And finally, probably the most difficult distinction to make between a pleomorphic liposarcoma and a myxoid pleomorphic liposarcoma is when you have this mix of fibrosarcoma-like pleomorphic liposarcoma. And to be completely honest, I think that there's soft tissue pathologists in the community that probably still think that these are essentially the same thing. So it's probably somewhat debatable, whether or not these are still the same thing or are distinct. But with mixed fibrosarcoma-like pleomorphic liposarcoma, you can have this myxoid stroma with the pleomorphic lipoblast. So going into this a little bit detail, there's actually an interesting series by David Creighton's and colleagues where they compared myxoid pleomorphic liposarcoma with a conventional pleomorphic liposarcoma, in which they did methylation profiling, and they actually found that both pleomorphic liposarcoma and pleomorphic myxoid liposarcoma, they actually co-clustered together and they aggregated together, which sort of suggested that they might be more similar than different in terms of entities. But interestingly, Josephine Dermawant a couple of years back had a nice series where they looked at mutations associated with each, and including a SNP microarray. And one of the interesting findings that they found with the myxoid pleomorphic liposarcoma is that they have this disposition to basically exhibit almost complete loss of heterozygosity, as opposed to pleomorphic liposarcoma, which do not demonstrate that by SNP array. This can actually be quite helpful when you're dealing with this on a limited biopsy by running a SNP array and identifying almost this complete loss of heterozygosity. So I guess the question is, does it really matter in terms of distinguishing between these two entities? And I don't really get too riled up in terms of some of this nomenclature, to be honest, but I think it is good to at least be able to communicate, basically communicate to your colleagues and clinical colleagues that you're dealing with this entity of a myxoid pleomorphic liposarcoma, again, whatever you want to call it, because it does exhibit a substantially worse clinical behavior than a conventional pleomorphic liposarcoma. And in our particular patient, unfortunately, has developed metastasis and is dealing with an advanced disease. So in summary, myxoid pleomorphic liposarcoma is a highly aggressive liposarcoma, has a distinct clinical presentation in young patients in the mediastinum. It lacks MD2 gene amplification or DDIT3 gene rearrangement. Has similar genomic complexity with pleomorphic liposarcoma, but does exhibit this distinct widespread loss of heterozygosity. Again, appropriate identification of this tumor can help the clinician understand the aggressive behavior of this entity. That's all I've got.
Thank you, Dr. Perry. We have time for questions and comments. Now we're getting close to the coffee break.
Have you seen any cases outside of the mediastinum in young patients?
I have not, as you saw, there are report, there are the series there are cases in that series. I have not ever made that diagnosis personally. A myxoid pleomorphic liposarcoma outside of that location. I don't know if anybody else has, but the only ones I've diagnosed, I think maybe 2 have been in the mediastinum in that specific clinical presentation of a younger patient.
There was a substitute pathologist at my institution that reported one in the organ of youngster.
We diagnosed one like 3 months ago in sinonasal cavity, and it was metastatic to the abdomen at the time of diagnosis. I gave you all the tissues last morning. But in Creighton's paper, 2 of their cases were sinonasal, like skull, so very rarely outside the mediastinum.
Thank you. Markku?
Yeah, I did one and first of my life last week, 2 days before this meeting, and I'm gonna show it. So it was in Czech, 5-year-old.
Ours was 21.
Okay, thank you. So the last speech for the session is by Dr. Gross. Please go ahead.
Okay, thank you so much. And I want to say thank you to Michael and David Suster and Michal for this incredible opportunity. The AMR is my second AMR. It's such a wonderful organization. I feel so grateful to be involved in it, and just really excited and grateful to be here in Pilsen. So thank you so much. Okay, so the case number 41, I'm pretty excited to talk about, so let's get started. So it's going to be a little story here. I'm going to start off with 41A. That's the one that you guys have in your little files. But we'll kind of hopefully tell the story the right way. So 64-year-old female, without a significant past medical history, goes to the emergency room and says she has abdominal pain. The CT didn't show anything in the abdomen, but did discover a 3-centimeter mass in her chest wall. So you can see this mass here, right there in the soft tissues in the chest wall. And the radiologic differential diagnosis described a bunch of things, possibly schwannoma, nerve sheath, et cetera, cannot exclude a sarcoma. That was then biopsied and sent to me in the consultation setting. So here's the low power photomicrograph of the core needle, and we see a clearly mesenchymal tumor with a stromal vasculature, right? Boom, right away. But then we also have the funny little hyalinized blood vessels, and then what looks, even at this power, very bland morphology, and a very hyalinized background stroma. Again, higher power, very, very uniform, very bland, not mitotically active, kind of spindled ovoid cells, kind of funny little hyalinization, but I wasn't really sure what the heck this is. Diagnostic considerations, I had many, and solitary fibrous tumor honestly was my first kind of thought. You know, there's these very rare PRX tumors, maybe an OFMT, but you know, potentially it wasn't, there was no matrix mineralization on radiology or in that biopsy, nerve sheath tumor, LGFMS, et cetera, or maybe it's something novel, I don't know. Did some stains, did have SOX10, nuclear expression, and it also had some S100. So, you know, is that just like a funny schwannoma? I actually almost called it that, but thank God I kind of pumped the brakes, just a pinch, and made up some stupid name. Bland mesenchymal spindle cell neoplasm, not further classified. Here's the IHC profile and suggested surgical excision, which rarely happens in those that do like consults. I actually got them to send me back the excision, which sometimes can be a bad thing, but I was really grateful for this case. So here it is, and notice, what I really want you to notice is that multinodular pattern. So there's a very specific reason why I wanted to show you this very low power. So again, very, very multinodular pattern. Again, clearly mesenchymal looking tumors rather than the soft tissue. You got a lot of vessels that are also HPC-like. Again, notice that multinodularity. It's a common theme I want you guys to walk away from this lecture with. Again, intermediate and higher power, again, very, very bland, hyalinized background stroma. Some of the blood vessels, quite hyalinized, indeed. So I still had to give it a kind of a dumb diagnosis, or I don't know diagnosis, I shouldn't say dumb, but I don't know, and said unusual bland spindle cell neoplasm, 4 centimeters. And then I kind of just was like, look, this could either be entirely benign or low grade, but I know it's not high grade. And then I said, I'm going to do some molecular genetics. So I did our targeted fusion panel at Johns Hopkins, and that was negative. I did a fusion panel at the Mayo Clinic, and that was negative. Then I decided to do a fusion panel at the Cleveland Clinic, and that was negative. And then I said, screw it, I'm going to send it to the University of Washington where I did one of my fellowships, and that was negative. And if you, oh shoot, let me go back. If you notice, actually, I did ask them, look, please look for this PRX, NCOA, all these sort of fusions. And then they specifically say, sorry, John, none of that was there. Or excuse me, the NCOA family. So then finally, I was like, calling in an expert, calling in a friend, phone a friend, and I asked Michael, would you sequence this for me? It's really, really interesting. So stay tuned. Case 41B. So it's a 36-year-old male, 3 centimeter painless supraclavicular mass, about 1 to 2 years duration. It was excised and also sent to me in the consultation setting. At very low power, again, you notice this really multinodular growth pattern. And clearly mesenchymal, got stromal vascular support, very pink tumor. Variably cellular, but again, notice that multinodularity. Hyalinized and stromal background, bland cells, and some of which have maybe a little bit of hyalinization of the vessels, but a very hyalinized, very vaguely myxoid stroma, but more sort of like fibrotic, but very, very bland morphology. IHC, again, S100 and SOX10, they were limited, but like unequivocal, but negative for actin, desmin, all these other sort of stains, DET6, M4, RB1 is retained. So at this time, I signed it out. This case came after that first case. So I signed it out the same way, and I said, look, this could be negative, or it could be novel, and I knew that I had something here. I just didn't know what it was. And I sent it for fusion analysis. And, no, excuse me, I sent that case to Michael too. So I sent Michael both these cases, telling him, I have something here. So I sent him that second case as well. So I didn't even sequence this with the other stuff, okay? Now, a friend and colleague of mine shared with me over Zoom another case. Her name is Dr. Markku. She's at the University of Indiana. And this is a 46-year-old female with 2.2 centimeter mass, case 41C now. Lower neck soft tissue, about 1 to 2 years duration. They thought it was a lipoma. They did not do imaging, so they did a simple excision. And the surgeon did say in his note, like, it was more fibrotic, lobulated, multilobulated than most lipomas that he had seen. At low power, these are photos from Dr. Warmke, multinodular neoplasm, very pink. Again, see these little like nodules sort of condensing the color of that scene. Very bland, very bland morphology, even from this low power, a very fibrotic and hyaline background stroma, clearly mesenchymal, bland morphology. At higher power, again, very fibrotic, bland cytology there, collagenized. Here again. She had done immunohistochemistry, and it has S100, and it also had some SOX10 expression. So I told her, look, I know what your case is, I just don't know what it is. I know what your case is, I just don't know what it is. So I told her like how I could sign out my other 2 cases. And this is how she signed it out, which I think is very reasonable. Talked about all this, and then she said that she's sending it to Mayo Clinic for their fusion assay. And for 41C, Warmke's case, it comes up with, surprise, surprise, PRX and CoA1 fusion. What about case 41B that I sent to Michael? PRX and CoA1 fusion. What about your case that you have in your file, case number 41A, the index case? Michael has 1,400 genes here, and PRX KMT2D. And it was a reciprocal translocation. More on that in a minute. So a revised diagnosis was PRX rearranged, KMT2D fusion to Mackinnon. So what are these PRX tumors? So initially described by Dr. Dixon on the left and Karen Fritchie on the right. They described it as these fibroblastic-looking tumors with NCoA1 or NCoA2 partners. So that's kind of how the 2 papers were described, essentially under-recognized and bland/benign tumors. So with these 3 cases, we found actually another 3 cases. Dr. Abbas gave me, an AMR member, as well as with Michael. We published a series of 6 cases. And we were pushing to change it from the NCoA family, because that was one of the reasons why all these fusion panels were negative. And we also wanted to make sure that people know that these things can be S100 and SOX10 positive. All of our cases in our series have indolent behavior, multinodular growth, remember that. Bland spindle cells, mixed with collagen stroma, staghorn-like vasculatures, SF-T-like, perivascular ionization. One of the 6 had adipocytic metaplasia, another thing we'll talk about in a minute. 50% had focal expression of S100 and SOX10. Can be a pitfall, actually this is Michael's words, which is great. Can be a pitfall or a diagnostic clue if you know that. Here's a photograph from our paper. Again, see the adipocytic metaplasia. Again, I showed this case earlier, but the multinodular growth. See that multinodular growth. So our paper further expands the molecular spectrum beyond the NCoA partners, and was mentioning S1 and SOX10 suggests partial neural or possibly even neuroectodermal differentiation. So the literature, though, also deals with one case that had a KMT2D that was kind of crammed, I think, into this paper. In here, the authors by Florian Pools. The authors actually talk about this PRX KMT2D fusion in their series. Now, they don't show the very low power morphology, but you can actually look at the gross. Notice how multinodular that is. Moreover, we actually included a gross photograph in our paper. It is beautiful. It should have included in this talk, but very multinodular, just like this, right? It mimics the low power the gross does. Notice they have adipocytic metaplasia, get bland just like our case. So, you know, they discussed, this was a couple of years, 2020, before our paper, but they actually talked about how this may actually be, in their sort of series, may actually be more in that of a PRX rather than this GAP1K and T2A family. They also noticed that their fusion was a reciprocal fusion, exactly what Michael and colleagues detected here at Bioptická. Dr. Warmke actually communicated personally with Dr. Puls, and he had said, yeah, I think that our case was incorrectly labeled in that series, and it belongs in the PRX. So, diagnostic tips. Multinodular growth. Hyalinized or stagnant vasculature. Again, 50% may be positive for S100 or SOX10, maybe focal, but just do a broad IHC panel, exclude stuff, right? Do 34, MUC4, STAT6, etc. But also, you know, there's really no fibroblastic differentiation, like actin, desmin, these are always negative in this tumor. And then the target molecular analysis may prove useful. And then, in the last like 2 minutes, I want to basically just hit this. We've talked about this for 41 cases already, but basically, the anatomy of a diagnosis, I think, includes many different buckets, right? There's the clinical, there's the radiology, there's the gross, histology, IC, molecular, right? And all of the 6 cases are important with each case. And it's like you're a lawyer and you're kind of like prosecuting the tumor and coming up with different pieces of data and saying, you know, well, the radiology says this, histology says this, the molecular says this, but I think the goal is to have orthogonal data to come to one specific diagnosis in the end. And you want to have multiple buckets all pointing to one answer. So with that, I want to talk briefly about sort of some molecular updates. Here's just a list, I'm not going to go through them, of select rare ultrafusion-driven tumors. As mentioned here, we actually a lot of these are been described by Michael and colleagues very recently. I will say this, at the very bottom here is a tumor called ossifying spindle and epithelioid tumor. And in February, Michael invited me and a bunch of other people to come and talk here. And I gave a talk on this ossifying spindle and epithelioid tumor. The day before my talk, I got a phone call from Hopkins to talk to me that they had actually identified this SRSF7 NFAT-C3 fusion. So I'll never forget Pilsen for this, that I was here in this room talking about this just a few months ago with tumors that we had already knew that they were a specific entity. So at the time when I gave my talk, I didn't tell anyone what the fusion was, but now our paper is, you know, almost all the way through the review process, so you should be seeing that pretty soon. But that's a sneak peek into that paper. A lot of different molecular updates very recently of fusions. Some of them, there have been rare tumors with the same fusion but different behavior. That's been talked about multiple times this week, including those here, as well as some that are driven by mutations, including the ERBV and the pseudoendocrine sarcoma. So when to sequence and when does it matter? You can do many different things, sometimes classified without molecular. The turnaround time, cost, all this sort of stuff can be important to consider. But then very summary, I just mentioned it's a very exciting time to be a bone and soft tissue pathologist. And as a pathologist, you should always maintain a very high index of suspicion, especially when you know that you're right and all the fusion panels are always negative. Thank you.
Thank you, John. We have time for one or two questions.
Just two comments. Thanks, John, for this nerve-wrenching story. I've seen, including your cases, 6 cases now, and they all have S100 and substantive expression. The key is it's very often very focal, so like 95% of the tumor are negative, and then you find a small area where there is expression. That's very, very helpful. Actually, I was looking specifically at this like a month ago, so I was looking back at my older cases from the last 2 years, and actually one case I described as being negative was actually positive. Just if I look carefully again, there was the expression. So I think many cases in the literature described as being negative are actually positive, just in some little corner out there. So that's very helpful.
For sure.
otherwise the fusion wasn't detected by me, but by one of my molecular colleagues. I just said that this is upstairs.
Well, thank you. Yeah, and it was very focal in my case as well. But I liked how you said this could be a pitfall or a helpful clue, you just have to know about it.
Thank you very much. First of all, incredible work and all this and insight that you are providing us with all the molecular. As a simple-minded old pathologist, hey, what are these cells? I mean, I still remember asking the stupid question, what's the cell of origin? Probably some stem cell.
Right.
And I would like to quote 1953 Dr. Johnson, who was a Johns Hopkins pathologist, and who said, histogenesis of tumors is like paternity. You know who is the father, who knows who is the mother, but the father remains questionable. So how questionable is the father of these cells?
Well, I think that the original authors tried to call it fibroblastic. It's a little bit funny in the absence of actin and the immunohistochemistry, but they sure look fibroblastic. So I think that in some ways that's fair, but yeah, I agree. Stem cell, some sort of connective tissue cell that just happens to have a aberrant genomic alteration that then drives oncogenesis. But they're not malignant, so they kind of have some sort of limited growth potential, at least so far.
Hello everybody. It's my pleasure to start the last session today. I've got permission from Michal and Marian Schweidler to stand here and welcome our honorable speaker. The first or third plenary lecture will be given by Dr. Mackinnon, Advances in Molecular Pathology in Human Neoplasia. The podium is yours. Thank you.
Thank you. And I figured we talked about advances in human neoplasia, we'd be here all night. So I got a little bit more of a specific topic in mind. So we talk about the impact of the new FIGO stage in endometrial cancer and the role of molecular subtyping. So just go over briefly the new staging if people aren't that familiar with it, we can review it, and then the big part of that is the molecular classification. And then talk about some examples, using some clinical cases, and then because this is a new paradigm, it introduces concepts in testing, and then when you have either limited tissue or limited resources or don't really want to do a whole exome or things like that, what are some good options that can be available? So in 2023, the FIGO introduced a new classification system for endometrial cancer. And this is the first change in 16 years. And during that time, this reflects changes and discoveries that were made. And the biggest one, probably that drove all of this, is this TCGA project, where 4 molecular subtypes were identified for the analysis. And we had a nice talk earlier today by Dr. Rywlin, where she went over the POLE and the MSI hypermutated, and then there's the non-specific molecular profile and the high, CN high, also known as P53. And so this introduced a new way to classify tumors, and then the subsequent years, this model was validated through retrospective analysis, the prospective analysis, and really what it started to do is introduce this concept of introducing risk to staging. And so, back in 2029, there was a classical staging system based on the extent of disease done surgically, and that's still incorporated into the 2023, but now it also incorporates some histological features like lymphovascular space invasion, grade of the tumor, involvement of the serosa of the ovaries if they're there, and most importantly, these new molecular changes. So now, you have the ability to do more specific prognostication, and this has a lot of influence on treatment for the tumors. And the big things that are coming out of this are this new upstaging and downstaging of tumors from the traditional way. So some women with endometrial cancer, depending on the mutation, for example, may need to be upstaged and get more aggressive therapy than they would have in the 09 model, and the opposite could be true too. They could be de-escalating the therapy. So obviously this is met with a lot of concern by clinicians and patients. So we're kind of in this phase now where these new systems are getting introduced. They'll probably spread to different diseases, but then you got to work through the changes they do. I mean, if you're the patient, you're being told you need to, like, you're fine, no more surgeries needed, you might not feel comfortable with that. So it's a really exciting time. So these TCGA introduced these 4 molecular subtypes, and then there was a way to do some really simple basic testing to serve as surrogates for these different molecular markers. And so you can do all this testing in one workflow, but there's an algorithm at which you interpret the results, where POL-E is the, okay, POL-E, that's the main thing that you analyze first. Then you look at the IHC for the MMR, and then the P53 expression. And the reason for doing this is because patients who have the POL-E mutation have really an excellent prognosis, and many places feel that if you have a POL-E mutation, regardless of anything else, you don't really need to do anything more with those patients, so you can consider yourself cured. And then the P53 type has a worse prognosis, and then the MMR and the non-cellular molecular profile kind of have the intermediate prognosis. And this is an interesting way of looking at the difference between the previous FIGO and the new FIGO. So when you look at the different, this is a cohort of 265 patients who were staged according to FIGO 2009. And then applying the criteria for 2008, 58 of these, and this is without using any of the moleculars, using only the anatomical descriptions, 58 of them were upstaged because basically, mainly based on the new aggressive histologies, and then a small number because they had substantial lymphovascular space invasion, which is known to be a bad prognostic indicator, and then 4 patients had been downstage, so it does change where people are. And then when you introduce the molecular aspect to it, 19 of these patients were added to this new stage that was created, the stage 1A molecular POL-E, and 4 patients were upstaged because they had the P53 mutation. And then, so this is kind of the framework. And then other groups then said, well, why don't we try and validate this? How does it look? So this study that came out last year looks at a huge number of patients, and it looks like their survival. So it took the patients when they were originally staged using the FIGO 2009 classification and these different categories. You can see it works. The higher the stage, the lower the survival. And then by applying this new staging criteria, it gets a lot more precise. So you can tease things apart even more, and they don't cross lines, and it appears to still work. And the implications from this are that patients who have these POL-E mutated tumors might have been receiving more treatment that was necessary from the old staging, and the patients with P53, even if the tumor is superficial, might not have been getting enough therapy. So these are the implications for that. And this is, I think, is a great example. This new staging recognizes the favorable prognosis of the situation where we have coexistent endometrial and ovarian carcinoma only under certain conditions. And this is based on the fact that they recognize that the endometrial cancer and the tumor that you see on the ovary is clonally related. They're not, it used to be thought these are 2 synchronous tumors that were completely independent from each other, but they're not. And so the conditions, though, are that the uterus has to be a low-grade tumor, less than 50% of the myometrium, and no lymphovascular space invasion. And with the ovary, it has to be unilateral and can't invade or rupture the surface of the ovary. And with that, these patients would go from what was historically a 3A stage to a 1A3, and they have a lot better survival than if they had been classified before. So it's an example of the anatomical changes that can happen. And then with the molecular, let's introduce some of these POL-E mutations in the P53. So in this example, you have patients, let's say, with the POL-E, that's shown here in this green. With the old FIGO 2009, they would have been staged at 1B or 1 or 2, and then with the fact that they have the POL-E, they come up here to this new category, 1A with the molecular POL-E, and so they can back off on the therapy. And the opposite would be these patients with relatively low stage, but a P53 mutation, they come down here and become a stage 2C. And the 5-year survival is much lower in these patients, whereas the 5-year progression-free survival will be much higher in the POL-E. So it's an interesting new way of integrating risk and staging and incorporating it all together into one system. So it's just starting to take hold now. So I'm going to show a couple of cases that can show some examples of these and talk about these different classifications. So the first one This is a case, it's a 61-year-old female, and what she had was a high-grade endometrial cancer isolated to an endometrial polyp. The tumor is 2.5 centimeters. There's no myometrial invasion, no lymphovascular space invasion, no adenomyosis, uterine serosa wasn't involved. It was proficient for mismatch repair and pretty just contained to this polyp. The histology shown here, it had high-grade features like papillary and solid areas, some high-grade nuclear atypia. You can see that here, and some of these cells are really large, weird hypochromatic nuclei. It showed a wild-type P53 staining pattern. So here, most of the cells are negative, most of the tumor cells are negative. The ER was mostly negative, with some patchy expression. AMR showed patchy expression. And so the IHC, it was challenging for the pathologist who signed this case out to make the histological subset type. The patchy staining for P16 that was observed was arguing against the serous carcinoma, but the ER and the PR were largely negative, and AMR was positive, so it could possibly be a clear cell, but it didn't look like a clear cell. And MAPSIN was negative. The P10 expression was lost, and that's kind of consistent with an endometrioid type, but then it was negative for ER-PR, which is uncommon for the endometrioid type, and proficient for the MLH1, the mismatch repair proteins. So it came to our lab, and we run a 500 gene DNA solid tumor panel, sequenced it, and the microsatellite, this assay can determine microsatellite instability status, and it was indeterminate, so you couldn't tell if it was stable or instability, but it had a huge mutation rate of basically 740 mutations was the TMB, and it had this POLE mutation here that was present. And POLE is one of the 3 polymerases that we have in our body. The other 2 are the alpha and the delta. And POLE, its main biological roles is during T and B cell rearrangement. It can help introduce some of those mutations you get in the antigen binding site. So it's a little bit loose, a little bit sloppy. But POLE has 4 subunits. Polymerase epsilon has 4 subunits, and the largest one is coded for the gene POLE. That's the gene that codes for the largest subunit. And what it has is 3' to 5' exonuclease activity. This is kind of like an eraser at the end of a pencil. So during DNA replication, if there's an error, it knows, it can identify there was an error done during the DNA being copied. It goes back and erases it and fixes it. So you can imagine if this enzyme is mutated, you're just going to accumulate tons of mutations, and it'll hit some important oncogenes or tumor suppressors and affect their function and lead to tumorigenesis. So it's just believed, mutations in this gene are believed to be an initiating event in most endometrial cancers and colon cancers. And the mutations, this is important, and we talked about this earlier, is the mutations in POLE that are important in endometrial cancer are all located in the exonuclease domain, which is right up here. So this is a hotspot domain. You can identify mutations in POLE that are not in the exonuclease domain. Those are challenging because those are kind of variants of unknown significance, and you don't know if they affect the exonuclease activity or not. Even if they're far away, the protein can fold and bend around, and it could have some allosteric effect, but you just don't know. But when it's in the exonuclease domain, consider it pathogenic. And it's interesting because, and there's just a few hotspots, and there's some more that are like less common that you can observe. But when you look at different organisms, this is a highly conserved domain, and these mutations all kind of line up in the same spot. So it just shows it's really critical for the function of the enzyme. So, as we also discussed earlier, there's not every patient necessarily needs POLE testing. So, basically, the patients who, and this could represent a fairly significant number of patients who you really don't need to do it if it's not available or presents extra risk, but you really have to satisfy all of these criteria in order to be pretty safe and not do the POLE testing. That is, you have to have an endometrioid histology, be grade 1 or 2, MMR proficient, P53 normal by IHC, stage 1A, and no lymphovascular space. If you see all that in the initial workup of the case, then you don't really, there's no reason to do POLE. Now, if any of these other features are present, POLE staining needs to be done. If it's non-endometrioid or grade 3. The reason for this is that you can unmask a low-risk POLE endometrial carcinoma that's masquerading as a higher grade, morphologically high-risk tumor. So if you have a high-risk tumor and you detect POLE in it, you can back off, according to the FIGO staging, you can back off on the treatment. Another important thing is, and this is important for all endometrial cancers, to do the MMR and P53 testing, because you can rule out mismatch repair deficiency or P53 abnormalities as being a secondary mutation due to POLE. So if you, and we'll talk about this in the next case, but if you have a P53 mutation in the setting of a POLE, it's POLE, because the P53 is thought to be secondary to the POLE. That's the thing. And also anybody who has stage 1B or higher, any lymphovascular disease, for the same reason, if there is a POLE mutation, you can de-escalate the therapy. Okay, so a really interesting question is, why is POLE associated with such a good prognosis? And the idea here, I think it's pretty interesting, is that when you have a mutation in the exonuclease domain of POLE, let's just say, for example, this P286R missense mutation, this starts to screw up the DNA exonuclease activity, and you start to get a ton of mutations. And eventually, there's other DNA repair systems that are present in the nucleus, like the non-homologous end joining and the HRD. Those will eventually start to get overwhelmed and become dysfunctional. And then DNA from the nucleus will start to leak out into the cytoplasm. And this damaged DNA, when it enters the cytoplasm, it stimulates the CGAS pathway. And this pathway then causes the tumor cell to start releasing cytokines out into the environment, and that recruits certain lymphocytes into it, and that's believed to be what helps to make the tumors behave so much better than other tumors. It's a little bit like the idea with MSI tumors, or defective mismatch repair. They make all these neoepitopes, and those attract T cells. This is another way with actually the cells sending out cytokines to recruit the lymphocytes to come in. So, there's some unanswered questions in this area. One is like, what are these cytokines? So I think a lot of researchers are trying to figure that out. But, another question is now POLE a biomarker for immune checkpoint therapy, since we're recruiting all these T cells to come in. And then what I think is very intriguing is, could you make drugs that target the POLE exonuclease activity, knock it out, and then be a surrogate for a POLE, like a synthetic lethal POLE mutation? So it's interesting. So interesting areas will come out of this. Now, in endometrial cancer, POLE has such a good prognosis, you might not really think about adjuvant chemotherapy, but POLE mutations are also present in other tumors. And so these immune checkpoint inhibitors are really effective in a lot of tumors, and there's 3 major biomarkers that are used for selecting patients for immune checkpoint therapy. One is mismatch repair or microsatellite instability. They're one and the same. Another is tumor mutation burden being higher. This is not normalized or universal, so some labs it's 10, our lab it's 16, or the expression of PD-L1 on the tumor cell. And these are all investigational biomarkers for immune checkpoint, and that includes POLE. So this study looked at a bunch of different tumors, not many endometrial cancer, less than 1% of endometrial cancer, and they looked at the POLE status and looked at the response to the immune checkpoint inhibitors. And patients that were high, had POLE pathogenic mutations, responded better to immune checkpoints. So there's some initial evidence that these could become another biomarker that would do a good job of predicting patients who may respond to immune checkpoints, but probably outside of the setting of endometrial cancer. Okay, so the next case is, this is an interesting example when you have like the POLE and a mismatch repair, or POLE and P53. So this is a patient. She had a large tumor and it involved her cervical stroma. The myometrial invasion went more than 50%. There's angiolymphatic invasion noted. And the rest of the tumor features are listed here. So this would have been by FIGO staging a 2C. And what was detected was a different POLE missense mutation, also a pathogenic one. And mismatch repair testing showed deficient mismatch repair, and it was MSI high, had a lot of mutations, a lot of variants were identified. So in endometrial cancer, the main reason that mismatch repair testing is done is to identify women who might have Lynch syndrome. It's primarily for screening. Also for prognostics and predictive value. And as you know, you can do it several ways. You can do it by IHC, which is the recommended way in endometrial cancer. You can do it by looking at the changes in the sizes of microsatellites. This is a conventional way. And now that we're in the molecular era, you can do it by next-gen sequencing. And that's nice because you can start to take all your assays that are different and start consolidating them onto one platform, and it makes the workflow a lot easier. So comparing and contrasting the POLE and the mismatch repair deficient tumors, they both have a high level of mutations, but the mutation rate in the POLE cases is much higher. That's why it's called ultra-mutated versus just TMB high. The prognosis in POLE is excellent, and mismatch repair deficient endometrial cancer is intermediate. It's not sure. Like in colon cancer, mismatch repair deficient is considered to be a very favorable prognosis. I don't think that actually translates entirely to the endometrial cancer. And then you can just see some other features of them, like the immune cell response, and it's unclear whether it's a POLE is, as we talked about, a good biomarker for immune checkpoints. It may be. And you can see these mutations in other diseases as well. So when we talk about this term multiple classifiers, this is seen about 3 to 6% of endometrial cancer. And what it means is they have more than one of these TCGA-derived biomarkers present in the tumor. So you have POLE and P53, mismatch repair and P53, POLE and mismatch repair, or all three of them. And it's, the percentages are shown here. So this is really an important and interesting thing. This is looking at patients who have POLE mutations not otherwise specified and looking at their survival. Then we tease apart the patients who have POLE involved in the exonuclease domain, which is the hotspot part. That's where the business part of the molecule is, versus patients who have mutations outside of that area and look at their survival. Can really see that the patients who have the pathogenic POLE mutations have like a 92% survival compared to the patients who have the non-pathogenic POLE. So it's really important to find these mutations, and then if it's in the uncertain area and you just really don't know what it is, it poses an issue. Like, how do you treat the patient then? It looks like the survival is not going to be as good, so maybe adjuvant therapy is more important for that. So it's good, it's important to know that. Okay, so we talk about our third case. This is another example of a woman. She had moderately differentiated carcinoma, was rated at 502. The tumor was 9 centimeters, extensive into the outer half of the myometrium. But the rest of it was more or less okay, except for there was a couple of lymph nodes that were involved in it. So this shows the mismatch repair staining, and you do these 4 stains, and there's this relationship between the MLH1 and PMS2, MSH2 and MSH6, and they bind each other. So based on the staining pattern, you can tell if it's Lynch syndrome or not, or which one is the major molecule involved. In this case, MSH2 is lost, and MSH6 is lost secondary to MSH2, because that's its binding partner. In the absence of MSH2, MSH6 gets degraded. Okay, so in this case, we did the staining, the sequencing. You find that it's MSI high, that's consistent with the IHC. Then there's a P53, two P53 mutations in this patient, and high TMB. So looking at the genetics and the patient's history, there's a pathogenic pathogenic MSH2 mutation, has a VAF of about 50%. And I didn't want to get into all the details on this case in the interest of time, but this is a germline mutation, and then this was believed to be a secondary somatic mutation. So the patient was born in about, I don't know what that'd be, like 64 years ago, with a germline MSH2 mutation. In 2005, she was diagnosed with colon cancer, was treated, and then came to our institution in 2007. With endometrial cancer. So, a lot of times with people with Lynch syndrome, you can get cancer multiple times in your life, whereas in people who don't have Lynch syndrome, it's usually a one-time event, all that. So she's lost the follow-up, so it's unclear. This is an interesting case. Here's a deficient mismatch repair with a P53, but the patient has Lynch syndrome. So does this multiple classifier still work in that patient or not? So it's just kind of an interesting constellation of findings. So when you look at these multiple classifiers, you have, and this example is mismatch repair with a P53 mutation, and that's shown in this line with a 92.2 survival. And then if it's just P53 only, the survival is much lower. And same thing when it's POLE and P53. So based on this, and this is the last part to this trial, which is interesting, is that patients with P53, typically the recommendation would be to get radiotherapy after surgery. But in this study, it's called the PORTEC-3 trial. they added a chemotherapy arm to it, plus radiotherapy. And the patients who got the combination chemotherapy and radiotherapy with an abnormal P53 had better relapse-free survival and overall survival than patients who just got the radiotherapy, but these other classes of Pol E or MMR deficient or the non-specific molecular profile, when they got either arm, it was about the same. So it looks like adding chemotherapy to radiotherapy, the only place you'll see the benefit is in the setting of a P53 mutation. Okay, so kind of putting it all together and looking at this, you can have this type of algorithm where you have the Pol E is analyzed first, then you look at MMR. So anything to the left, coming down, mutated Pol E, no matter what all the other stuff is, it's Pol E mutated, Pol E mutated, or Pol E mutated. You can, it's about 8% of patients, this could be a de-escalation of treatment. If it's a mismatch repair, IHC shows deficient mismatch repair, same thing, it's deficient mismatch repair or deficient mismatch repair. Important to know, because you might look into Lynch syndrome, but these patients should have a benefit of using immune checkpoint therapy if that's option to them. And then if it's proficient mismatch repair of the P53 abnormality, can consider adding chemotherapy to the radiation therapy. And then new, not quite ready for prime time, on this non-cellular molecular profile, it's looking like patients whose tumors stain positive for ER will have much lower risk than patients whose tumors that should be ER negative that don't have ER. So this would be the higher risk patients. So we can maybe see in the future if ER enters into this equation. So it's kind of nice. It's really just 5 or 6, depending on what panel you're using, immunostain markers and one molecular test. Okay, so now talking about how do we test for this. I'll just take a little detour to here. And this was work done by Dr. Kanako Okamoto. She's visiting our institution from Japan for a couple of years, and she was working on this project. And as you know, the idea would be, the best case would be you get one sample, you do one test, you get all this information in one test, like an NGS test, and all that. But the problem is it takes a while to consolidate testing. So we're talking about in the interest of, or specifically for mismatch repair, we have the IHC test, the PCR testing, and the next generation sequencing. These two are kind of complementary. A lot of labs do both. Next generation sequencing is getting more and more popular now that it's increasingly available. So we were asking, okay, if we wanted to do this testing, what would be like the most effective, efficient option? Would you do as like just the baseline whole exome sequencing, where you sequence about 2% of the genome? It's much more expensive, longer send outs, you need a lot more DNA input, and sometimes the coverage is a little lower, so it might be less accurate, versus like at our institution, we have a real quick overnight 50 gene panel, or it takes about a week to run our 500 gene panel. It's shorter, faster, it uses less DNA, it's higher, and and it also supports the lab. So let's just compare the functionality or the efficiency of these different panels in the context of, first off, finding just FDA-approved therapies for the patients, and second, looking at the FIGO 2023 classification. So we talk about what are these clinically significant or clinically important alterations. What we're talking about are this framework that was proposed by AMP and ASCO and several other organizations, and it's divided into 4 tiers. Tier 1 is subdivided into Tier 1A and 1B, and these have really strong evidence for clinical benefits. So Tier 1A are FDA-approved therapies. So like classically a lung cancer with an EGFR mutation, getting a tyrosine kinase inhibitor. And with each disease, there's different numbers of FDA-approved companion diagnostics. Like lung cancer has a lot of them, some diseases has very few of them. And then the Tier 1B would be, there might not be FDA-approved therapy, but NCC and guidelines, and everyone uses them for guiding therapy. And I think an example would be like P53 in endometrial cancer. Tier 2s are really important because if there's not a frontline therapy or patients relapse and you're looking for experimental therapies like clinical trials, you'd be more interested in the Tier 2, they're called Tier 2Cs. And then the rest are more VUSs, you don't know what to make of them, or benign variants. So we had 5 years of whole exome testing. It represented about close to 1,000 cases, and there was 521 what we believe to be somatic mutations were identified through 8 different diseases that we looked at, which included endometrial cancer. And for all these variants, we assigned one of these AMP tiers to that variant, and that's what Kanako did. And then looked at how many clinically actionable variants were identified total of this cohort. And with like endometrial cancer, soft tissue tumors, and pancreas, there's hardly any were identified, like 1% or less. You start getting into ovary, lung, colorectal, or breast, there's a lot more actionable variants, and that's just due to the nature of the therapies that are available in the diseases. So the result from this is the number of clinical alterations varied widely based on the disease, with those 3 I described earlier, endometrial, soft tissue, and pancreatic, not having very many. So you could probably use a much smaller panel if it was those diseases. As you get to bigger panels, you might want to think about more genes, because you might have to look for some. So we actually then next directly asked that question. So I wanted to know which of these mutations are covered by these different panels. And I'll just, in the interest of time, only focus on endometrial cancer. So this set of like Venn diagrams, this biggest one is all the mutations you find using whole exome sequencing. Then looking at the 500 gene or the 50 gene. So for the genes that are covered by the FIGO, which you need POLI, MSI, P53, you can pick them all up with the 50 gene. And then for the genes that you need for treatment, identifying FDA-approved therapies, also the 500 gene. So it'd be pretty safe. You don't really need to do the whole exome sequencing to get the information you need to effectively treat the patient. So now this whole cohort of 5,210 variants, only 91 were these AMP tier mutations. So only about 1.7% of all variants were clinically actionable for frontline therapy. KRAS and PIK3CA were the most common, and of the 91 genes, 84 could be picked up with like either a 50 gene or a 500 gene panel, and the ones that are missed are ones that are usually copy number variants, so the panels aren't necessarily designed to pick up copy number, so that was the reason they were missed. And then for the endometrial cancers, for FIGO, identifying them, the 500 gene would be the best bet. So you can use that panel and pick up and be able to clearly categorize the patients using this new FIGO therapy. So the last part of this talk is talking about some work that I did with our colleague Darshan. He's a new faculty, he's a bioinformatician. It's been super helpful for us to do a lot of analysis of our data. So this is an interesting case. It's from 2017 as a really small endometrial adenocarcinoma. It was 0.7 centimeters in greatest dimension. It only invaded 3 millimeters, and it was a stage. Where I work, they still use a FIGO 2009 staging, so it was a T1A. And when we did the testing, when we did the MMR testing, it showed loss of MLH1 and PMS2, and the MLH1 gene was hypermethylated. So this is a somatic loss of MLH1 and PMS2. But when we ran our NGS, it showed microsatellite stability. So this is discordance. And so for the rest of this talk, I'm talking about this discordance. And just to make sure I don't misspeak or to be really clear, the discordance means that you do the IHC and you show loss of the protein expression. So it looks like it should be MSI, but when you do the molecular testing, it's not MSI, it's microsatellite stable. Okay, so that's what I'm talking about. And this is not really well, it's known to happen in endometrial cancer, but it's not really well characterized. So we wanted to investigate a little bit further. This is important because if you're thinking about it, as you're consolidating all this testing in the next generation sequencing, so you're going to you might be tempted, or someone else might be tempted to, or they might not even be able to do the IHC. So they'll go, okay, we'll do microsatellite instability testing. Well, how often will this discordance happen? And if it does happen, are you kind of defeating the whole purpose of doing microsatellite instability testing because you're screening for women who have Lynch syndrome? So if it's stable by NGS, then you're going to miss them. So it'd be a false negative result. So there's a lot of reasons why you can have this discordance, and they're listed here. You can have low tumor cells and all this stuff that seems very, very logical and straightforward. But I really think there's a different reason, and the real reason, and that's shown here. This is a case of an endometrial cancer, and there's the H&E, and this is MSH2 staining. You can see it's beautiful loss in the tumor cells, perfect preservation of the stroma. And here would be a classic tracing. When you do MSI testing, you look at these microsatellites. This is an example of one microsatellite from DNA derived from the normal cells. And these are, I apologize, I mislabeled these when I was preparing it. So this should be normal on top. But the normal cells and the tumor cells, you look at the size of the microsatellites and you just compare them. And what I did in the bottom was just took these two tracings and superimposed them on top of each other. And when you look at the bottom, they more or less look like the same. So you might think, oh, this looks like it's microsatellite stable. But they're not. There's one nucleotide shift in 4 out of the 5 microsatellite markers. And there's really no cutoff when you're looking at microsatellite instability to know how many do I need to lose to be called MSI or not. So I used to do this. I just, you kind of blow that off and think it's stable because you don't get out of rule. It's really hard to see in real life when you're looking at these tracings because you don't superimpose them or look that carefully. So based on this, we decided to okay, so if you have loss of expression, think of that's like the MSI genotype. There's a mutation that causes a protein to not be made. So MSI is actually like the phenotype, just like high incidence of cancer, stuff like that. So this is the type of phenotype. So if you add up these shifts, you can kind of quantify the MSI phenotype in patients who have defective mismatch repair. So we did that, and looking at these different microsatellite markers, we can see that the red lines are endometrial cancer, the black lines are colon cancer. You can just see the distribution of the loss of nucleotides. So if you were to add all these up, that would be the complete phenotype. So now we're looking at each one of these markers. And you can just see endometrial compared to colon cancer for each one of these markers. And what these white little notches are, that's the kind of the median. It's just weaker in endometrial cancer than it is in colon cancer. So you draw a distribution and you look at these bar graphs, the endometrial cancer is shown in gray. And so there's a spectrum. Even endometrial and colon cancer, you have weak MSI phenotypes and strong MSI phenotypes, but MSI compared to colon cancer is just weaker. So maybe the reason that this stuff's getting missed by NGS is because it's just weak, and wherever the cutoff is, it's on the wrong side of that cutoff, and so you're just not gonna pick it up. So, given that it can be missed by molecular testing, it's major implications for this one-stop testing and for FIGO, and patients are at risk of a negative result. We want to ask a few questions. Is there any clinical pathological relationship to this MSI phenotype? I'm hoping maybe this is a subset of defective MSI tumors that have a weak phenotype and might behave differently. I was hoping something like that would happen. These are thought to recruit lymphocytes. So is there a different amount of lymphocytes coming in the tumor? How often do you see this? Are we just focusing on something that's really rare and it really never happens, so it doesn't matter? And is there a molecular profile for each one? So real briefly, I know we're kind of wrapping up the time, so we don't have just a few more slides, we'll just kind of walk you through what we found. So in terms of clinical pathological features, what we're doing is we're looking at women who have deficient NMR tumors, and they have the MSI, and we took them into 2 cohorts, the weak phenotype, the very end of one spectrum, and compare them to the super strong one. So you're kind of the 2 polar ends of the spectrum. And the only thing that is that patients who had high MSI phenotype had higher grade tumors than patients who had the weaker MSI phenotype. And that's it. Other than that, there's no real difference pathologically and clinically. Next, we want to look at the tumor-infiltrating lymphocytes. The idea would be if you had a weak MSI phenotype, you have fewer T cells than if you had a strong MSI phenotype, more neoantigens, more T cells. So took 10 cases of each, because unfortunately that we're really limited by the number of cases we have. They're kind of hard to find. And when we looked at the CD3, CD4, CD8 numbers, we did digital scan them and quantified them. There really wasn't a difference these are all MSI cases, but the weak versus the strong phenotype, there wasn't much. We could find no difference, even though it's a very small sample size, so it's you could be limited by that. So then lastly, or getting to the very end of it, how often do you see this discordance? And we saw that in a case of 45 primary endometrial cancers that we had sequenced, and 17 of them were negative by IHC, 5 of them were stable by our FDA-cleared NGS assay we run in our lab. So it's about 30% discordant rate. So it's fairly common to observe this. So kind of just cutting to the chase here, these discordant cases, show a very similar mutation burden as cases that are proficient for mismatch repair. This line shows the cutoff. The one on this side are concordant for loss of NMR, both MSI high, and these are proficient for an NMR, stable. And we had 5 cases in here that were discordant. They had the same TMB as the proficient cases. The mutation spectrum, this is looking at the major mutations. You can see that the patients that were concordant for loss of MMR and MSI have many more mutations than the patients who were stable, and right here in the middle are the discordant cases, and they act a lot like the stable. So we're kind of hoping that maybe there'd be a molecular signature that you could add to your NGS, but there isn't one that we could find. And so lastly, this experiment, we had 3 patients. This is a woman who had an endometrial cancer diagnosed in 2017. It showed by NGS, it was microsatellite stable, but by IHC, it showed loss of expression, so it was a discordant case. She had 4 mutations, we sequenced her, and then 4 years later, she had a metastatic lesion to her lungs. So, and we had the tissue for that. And so these are really challenging to find. When we looked at resequenced the lung lesion from her metastatic endometrial cancer, she went from being, her TMB went from 3.1 to 41.5, so it was TMB high, and the microsatellite stability went to microsatellite instability, and she had the same original mutations in all these new ones. And then another patient saw the same thing. She had also lung mets about 6 years later, and she went from microsatellite stable to microsatellite instability. This as a control, here's a patient who was concordant, mismatch repair deficient, and MSI, both that primary diagnosis, and she had metastatic lesion to her colon, and stayed microsatellite instability throughout the disease. So it doesn't go backwards the other way. So it makes you wonder, if you think about the time 0 being kind of right down here in this corner where you get a mutation in one of the MMR genes, you lose the expression, and then you have time on this axis, and then phenotype here, so the accumulation of mutations. If you diagnose someone on this side of the line and you're below the sensitivity of your assay, you run the risk of having a false negative result. But if you're on this side of the line, it's a late diagnosis, you can have a true positive result. So if endometrial carcinoma is often diagnosed early, maybe just this phenotype hasn't had time to catch up to the genotype, and you don't know why, perhaps this is just early detection, then you can have discordant IHC and MMR. So it's really important just to do MMR testing, not do the NGS. And then maybe 70% of the time is concordant because you're diagnosing the patient later and these mutations have had time to accumulate. And in contrast, colon cancer, you never really see this discordance, so it's possible that it's just diagnosed much later. Maybe people have it in their body a lot longer. Alternatively, maybe just the kinetics are different, and then colon cancer is just the phenotype accumulates quicker compared to microsatellite. But anyway, it's interesting. It appears that it catches up over time. So I think that was it. Oh, here, the take home is like the FIGO 2023 is important. It's blurring this staging with risk stratification. So I think it's a really exciting time, and it probably does represent a future paradigm for how we analyze tumors and use this for the risk stratification. We talked about whole testing, and not everyone needs it, but a lot of times you're doing these consolidated testing, so you're probably going to do it anyway. And then the last thing to say is, be careful when you're using an MSI with NGS, because you do run the risk of missing patients, and IHC really is the best option for testing in endometrial cancer. So I thank my colleagues back where I work in Alabama, and some other people we've worked with, and thank you guys for sticking around and for being here and attending.
I am not the best moderator of this session, however, I would like to express my gratitude and congratulations for a wonderful talk. Is there anyone, like Dr. Bioptická, Alex, would you like to comment? Because it's always, in my eyes, it's a success of the lecture if someone has comments or questions.
Actually, it was an excellent presentation. Thank you, Alex. And it was very nice that you essentially presented the work trying to guide which cases really we need the poly, because the test is expensive and not everybody is able to afford that. And actually, countries like Estonia, where they have with universal testing for poly, in Denmark, many hospitals did the poly testing at the beginning. They claimed that the majority of the cases that were low grade, essentially, that was money that was essentially wasted. So just targeting the cases where you really need to do the test is a great way to operate, because going universally really for the world, we're not talking about countries that can really, they have the resources to go into this massive testing, and if we consider the world as it is, it's impossible to get all of this done. Also, the fact that you integrated the information about, this is a risk model system actually, because remember that when FIBO was developed, it was just to determine the extent of disease, which allow rapid communication between oncologists from different parts of the world. So you just needed to know how extensive was the disease. And one of the criticisms is that now you're not only assessing the extent of disease, you are like creating a risk model just to know which cases are going to behave in a way. You're not implementing this system, essentially that rapid communication that could occur among colleagues from different parts of the world, people that have access to testing and people who do not have access to testing, is going to be somehow difficult.
Thank you so much. Any other comments from the audience? Thank you. If not, I would like to invite the second speaker. The next keynote lecture will be given by Markku, Miettinen.
Good afternoon. I will first highlight the technology with few slides, and then mostly show live examples how methylation classifier was used and how it worked. So 2018 was developed the frame classifier, and 2021 the first version of soft tissue methylation, or it's called Sarcoma classification, but it contains more than sarcomas, some benign soft tissue tumors also. So methylation classifier idea, somehow, if you compare it with any other diagnostic modality, it's closest relative to RNA expression or expression profiling, but it is like a mirror image of expression, because we are looking into methylated genes which are shut down by promoter methylation. The technology is complicated, and honestly, even if I read this beautiful article by my colleague Papanikolaou Senkos, I still didn't understand everything. But I recommend this article if you are interested in reading the basics and the technology of methylation. So we utilize extracted DNA from the tumor, and then get the methylated cytosines there with the doing bisulfate conversion, removing the non-methylated cytosines. That's the one principle, and this is done with a bead chip, or says also microarray, but it's a little bit different from a microarray what we used to see in tumor microarrays. It has 850,000 DNA probes. How can you put it in one, like a slide-like thing, you know? But how it is, there are bead chips, which means like mini nanoparticles that are enveloped by DNA probes. That's the idea, that's how it works. Then with AI, there is like a place in the map for the tumors. And here you can see, for example, we see here, are you seeing anything? Yeah. Okay. Leiomyosarcoma in the middle. Up here, angiosarcoma. Alveolar rhabdomyosarcoma here. On the far right, far left here, synovial sarcoma. Here down, endometrial stromal sarcoma. So these are just examples. And there are two different, like a map types, and one is the TSN, which is this, and the other can be also used alternatively. So now go ahead. Here is results of our first about 1,000 tumors, and we put just about everything in methylation, and we learned pretty soon that in many cases we could not get anything. And of course it has to be known now that there are only 62 entities in the methylation classifier, so you cannot expect any calls for entities that are not in there. Rather, what then happens, that other tumors, they are called something in a methylation that little bit resembles it, but is not really that. So the methylation call for entity is something that at this time you have to somehow back it up, especially when you clinically are validating methylation. You really have to do another way to really verify it, and it can be immunohistochemistry or RNA sequencing or sometimes DNA sequencing. But what we learned with our first 1,000 or 1,500 cases is that methylation is really good in specific fusion tumors, like B-core sarcoma. We had 3 there, everybody was recognized. Synovial sarcoma, excellent, I think 1 was only missed. Dermatofibrosarcoma, really good. Same endometrial stromal sarcoma, so these are all fusion tumors. But then there were bad apples there. Let's say inflammatory myofibroblastic tumor. Sensitivity was 100%, really good, but specificity 31%, because lots of tumors that happen to have a high lymphocyte content were called inflammatory myofibroblastic tumor, that we learned. Same thing in Langerhans histiocytosis. Our actually one only, yeah, it was recognized. But then lots of tumors that contain histiocytes were called Langerhans histiocytosis, whatever the tumor was. So that's a weakness of methylation. Then where it struggled, the methylation here, looked like a neurofibroma. Nothing comes out. It doesn't recognize neurofibroma like you put intraneural neurofibroma, which is just all neurofibroma. No, it didn't. And then you get a neurofibroma called from all kinds of things inappropriately. So that was one of the worst, really. And I think now I'm gonna just move to the examples and see if there is anything else interesting. So why it fails in different cases. So of course now bone tumors is a problem if they are acid decalcified, because DNA strand is just spliced to single nucleotides, so then you can't get anything out of it. So you have to have EDTA decalcification with bone tumors to get out of anything. Then low tumor content is bad because the methylation takes its clues from the secondary cells, and then lots of lymphocytes, lots of histiocytes, and you get something like I just mentioned. For example, tenosynovial giant cell tumor, as we know, the real tumor cells that have the CSF1 fusion, they are maybe 1% or less of all tumor cells. So how can it recognize it? It can, because when we put tenosynovial giant cell tumor methylation, it always all came out with the histiocytoma or Langerhans histiocytoma. Same with lymphocyte-rich any other tumors. And epidermal content is deadly for methylation now, because we have a lot of shade biopsies now. We get lots of from dermatology laboratories, for example. And here is a spindle cell tumor. You don't really see it very well here. We were trying this. What did the methylation say? Squamous cell carcinoma. No, it's just benign squamous cell here. But it also does not recognize in many cases benign and malignant, because it's lineage recognition what the methylation does. So here, as you said, the methylation goal was 0.99, very high clinical match for squamous cell carcinoma here. But it's because it has so much epidermis back here. Fibroblastic tumor here, and I didn't recognize this, tumor. Now it's SMA positive, so now many of you already know what it is. But here I didn't. It's kind of a little bit funny, collagenose and nondescript benign. But methylation nodular fasciitis, heavy. And I did USB6 rearrangement, was positive. Nodular fasciitis. Then, for example, dermatofibrosarcoma protuberans is very good target. This one did not have PD-GFP fish, so that's why somebody sent it to us and can we check it out. Yeah, it is still dermatofibrosarcoma, like methylation says, but it had alternative fusion, amylin 2, PD-GFD. So methylation also can catch the alternative fusion in many cases, as we have found. Here you can see a little boy has this tumor with Staghorn vessel, so you think now it's CD34 positive, you would think it's gonna be maybe solitary fibrous tumor. But STAT6 negative, but S-mean, keratin, S1 and SM, everything else negative. So what is this NTRK fusion sarcoma? But what did the methylation say? Methylation say it is MPNST-like. And this is what if you put NTRK fusion tumors, you often get this MPNST-like. That's what we found. Here is another one, staghorn vessels. Again, you would think solitary fibrous. It's a little bit young version for solitary fibrous tumor. Could be CD34, yeah, a little bit, but no stat, so maybe it's not. And what is it? It's actually ETV NTRK3 fusion sarcoma, meaning infantile fibrosarcoma. Methylation causes infantile fibrosarcoma. So that's a very good consensus. This tumor type baffled us a long time, and we probably missed so many. But now we started to understand this. Everything negative here. So melanoma, you would think, no, it's nothing positive here. I thought even adrenal cortical carcinoma, SF1 negative, desmin, no, keratins, nothing positive. So what did the methylation say? Methylation says melanoma, but only 0.6, but NRAS mutation codon 61, that's a very good melanoma mutation, and TP53 and their promoter mutation except for melanoma, so undifferentiated or dedifferentiated melanoma. With this we have learned to recognize now, and methylation is sometimes good, and sometimes actually neuromethylation gives you higher score than the sarcoma methylation in dedifferentiated melanomas. Here is a chest wall mass. This man had a melanoma, but nothing positive, it's just like desmin and myogenin, so it's like rhabdomyosarcomatose. But it has a RAF V600K. This is actually alternative RAF mutation. Here it's usually E. And brain methylation gave melanoma. Lower score. So this is another undifferentiated melanoma. Rhabdomyosarcomatose skin tumor here. Desmin, little bit myogenin, no substem, no nothing. Keratins negative. Methylation, melanoma, cutaneous. Rhabdomyosarcomatose evolution in melanoma, and it has NF1 driver, which is common in certain melanomas, TP53, and CDKN2, common in melanoma, loss or mutation here, and then third, again, promoter mutation, right? So that's another undifferentiated or transdifferentiated melanoma that became rhabdomyosarcomatose. This tumor was expected to be alveolar rhabdomyosarcoma, desmin, myogenin, but it failed FOXO1 testing in fish. That's why we got it in consultation. What did the methylation say? Alveolar rhabdomyosarcoma. Full points, 100. And actually, again, alternative fusion. But PAX3 is same, but here is NCOA 1 instead of FOXO1. This is a little bit Ewing-like sarcoma, but as you know, it's not Ewing sarcoma, extensively necrotic, and there is like a perivascular preservation. So many of you know what it is. Methylation also is pretty good. CIC altered tumor, and now we do a 1-immunostate DAX4, so this is CIC DAX fusion, which used to be called Ewing-like sarcoma, but now of course we call it CIC ducts diffusion tumor or CIC rearranged tumor, as the methylation says. This is a tumor type I struggled very long time, and I think I missed a few probably in the past. Luckily didn't get in trouble with those. But here, now Immunos again, hey, gives nothing here. And I thought maybe it could be EWS SMAT diffusion tumor. I just about heard about that, maybe saw one. No, it wasn't that. Okay, what is it? Spindle cell rhabdomyosarcoma sarcoma. And this is difficult often and can be very little Desmin positive of many cases, but lots of MyoD1, so high MyoD1 positivity, and here methylation goes right away. MyoD1 rhabdomyosarcoma sarcoma, but histologically we call it spindle cell rhabdomyosarcoma sarcoma. Here is another one in a knee, a little bit Desmin here and there, so this my first thought was this gonna be now malignant tenosynovial giant cell tumor. Had quite a bit of histiocytes too, SMA a little bit here, myogeny, a little bit, but not much of anything. What does methylation say? Again, rhabdomyosarcoma MyoD1, it actually was MyoD1 positive too. And spindle cell rhabdomyosarcoma has some morphologic diversity, you can see now here. And they can be, sometimes it's huge tumors, sometimes it's small tumors, and head and neck areas, and lower body or genital areas quite often. But this is something which is good to remember when you don't know what the spindle cell tumor is. Think about spindle cell rhabdomyosarcoma and do the MyoD1 immuno, that's the very easy thing. Here is a uterine tumor. You get cartilage and you get spindle cells, but there is also MyoD1 here. So now we know what it is, but methylation can say Dicer 1 rhabdomyosarcoma, and actually many, and perhaps most of the genital rhabdomyosarcomas, especially in benign and cervical rhabdomyosarcomas, are Dicer 1 associated with them, and that's mostly germ cell mutation based. When you have a crushed tumor, you are in trouble because you can't get any good clues here. And immunos, hey, you don't know what immunos you even do. This is a skull base, and now, of course, we did on many markers here, nothing positive. So now we put methylation. Hey, methylation says hemangioendothelioma, epithelioma. Hey, then we do just CAMTA1 nuclear positivity. Yeah, methylation was right. Just could catch it because morphology was bad. But then you have another epithelial hemangioendothelioma. This is totally different. This is first, does not go to methylation as different. It's different methylation class in itself, certainly. And that's a TFE fusion tumor here. And this was the alternative. It's actually often different than WWTR1. Now I can't even remember what the canonical fusion type is. Angiosarcoma is pretty good also. And now you see it's 0.96. And then when you get here to this copy plot, so on top of the diagnostic call, methylation has also DNA copy number plot, which is very valuable. And in many tumor types, the copy plot is more important than even the methylation calls itself. I'm going to show you some examples. But here you can see what is good for angiosarcoma here, and especially radiation-associated angiosarcoma, whether it is natural radiation like sun radiation, solar radiation, or medical radiation, and it's a MEC amplification. Right here you can see in chromosome 8. And then TP53, so a very non-specific DNA sequencing result for this group, for example. So it doesn't help much if you say it's TP53 mutation, it's not very diagnostic. Here, this is actually sarcomatoid squamous cell carcinoma. It kind of looks like not squamous carcinoma. Here is CK56 positivity. And methylation, hey, what did it say? Yeah, it made it. Methylation made it, but a lower score, but it's pretty good though. And, oh, there's lots of mutations. But would have difficulty to tell with this that this was squamous carcinoma. This was a tough one, you know, histologically first. So we actually, my colleague and geneticist Jerzy Lasotahidi, Archer at that time in our research lab, and he got the fusion here, but we also got methylation. Fusion was B-core CCNB3, B-core beautiful immuno, strong, so that's a methylation catches, as happened to all our B-cores we have done. And then also B-core IPD cases in catches, and one of them is clear cell sarcoma of kidney. Lipomatous tumors is, I would say, maybe 15% of our soft tissue consultations. And now I started love lipomatous tumors because methylation is so good in there. And the goodness does not come the methylation diagnostic call, it comes from the copy plot. And like here you see, this looks a little bit like lipoma. It doesn't look like a good liposarcoma. Hey, but it's MDM2 amplified chromosome 12 here. Are you seeing chromosome 12 highlighted there? Actually here. So there is the MDM2, and then a little bit down of MDM2 is CDK4, and they are variably together or separated case by case. And then here is a pretty bad-looking tumor or undifferentiated. But if you have abdominal sarcoma, which looks like this, number one always liposarcoma, and here dedifferentiated liposarcoma. And let's see what the methylation says. Methylation says undifferentiated sarcoma. It wasn't totally right, but hey, look at the chromosome 12 again. Massive MDM2 amplification, CDK2, and almost nothing else. So dedifferentiated liposarcoma, we call it. Here is another one, undifferentiated. Immuno is not good for these, except MDM2 immuno, quite good. And again, lots of MDM2 amplification in chromosome 12, and then other changes and zigzag. When you get zigzag changes here in the copy plot, it often means chromophysis phenomenon. Also spindle cell lipoma, which actually histologically is pretty trivial, so you don't need methylation or anything. CD34 immuno positive. And what does methylation say? So it says, okay, I know I have to press this one. Okay, here. Dip in chromosome 13 and RB1 is in the dip there. So that's good sign for spindle cell lipoma. Here is a little cluster of cases where I failed first to do the right diagnosis. scrotal mass with like this and cartilage, what would you say? Hey, I thought D-differentiated liposarcoma, also MDM2 immunopositive. But then let's put it in a methylation. What does methylation say? Methylation malignant peripheral nursing tumor. Aha! And is there MDM2, very little MDM2 amplification, or maybe just gain, little gain, but not good amplification. CDK and 2 loss, aha, that means something. And also, look at this, trimethylation of histone 3, codon lysine 27, right here, loss. So that's an excellent sign for malignant peripheral nursing tumor. So that's what we finally got. This was a mediastinal tumor, huge mediastinal tumor, and you get so much keratin here and epithelioid cells here. I thought sarcomatoid carcinoma. Yeah, I was wrong, because what happened here? So again, methylation causes malignant peripheral nursing tumor, high match. Hey, how about trimethylation loss? It is there. And what else? There is CDK and 2 loss is pretty good, typical of MPNST. And then now you start looking the MDM2 status here, and it's not that much elevated. Here was a tumor, I also struggled with this one. Widespread intra-abdominal tumor, immunos negative, no KIT, no DESMI, no SMA, just necrot, high-grade tumor obviously. And hey, if your diagnostic lines are like this means you don't know what it is. So it's like 20 immunostains done. What did I call it? I call it sarcoma at least intermediate grade. And then we put in a methylation, and methylation says GIST. And what did it say? Sequencing. PDGFRA mutation, which is the most common here, the D842V mutation. And these are the PDGFR mutations don't have always any KIT positivity, so that we have learned. Actually, they may be, but they're not even all positive for DOG1. Okay, now I think I was expecting to have my pleomorphic spindle, myxoid pleomorphic liposarcoma. Actually, this was an older version, 2 days older version, but I'll tell you, methylation it did not call it that. Of course, it called it well-differentiated or de-differentiated liposarcoma, but it had beautiful copy plot where there was haploidization of genome in half of the chromosomes. So I just described it. But maybe also it's good because we may be a little bit late. So you get out in time. So methylation classifier is not yet perfect, but the new version is coming very soon, and our 1,500 cases are there also bolstering the data. And then when you do methylation analysis, you cannot blindly believe what it says, especially these early days of sarcoma methylation, you have to, in many cases, double verify it. RNA sequencing, DNA sequencing, or proper immunostain. But many tumor types, like specific fusions, are really promising and highly useful. And then there are examples like small biopsies that don't have many histologic clues. Those methylation can be useful. We keep doing it for now, and if any of you, if you get case 1 or 2 and you think it would be useful, we'll be happy to take your consultation. Thank you.
Thank you very much, Markku. Please comment or any questions?
These are difficult cases that you are putting through, but is that going to change the diagnosis of the tumor that we call undifferentiated pleomorphic sarcoma, or is that category going to disappear completely?
Yeah, yes, that's a good question, because methylation struggles with undifferentiated sarcoma. And for example, we put about 10 dermatofibromas in methylation, and the old classifier, the version 1, which is still going, only 7 out of 10 with a high score of undifferentiated sarcoma from benign dermatofibroma. So then, as we know also, undifferentiated sarcoma is genetically highly heterogeneous, and there are different pathways for undifferentiated sarcoma. So various mutations and then different copy architecture. So there are like tetraploidy tumors, there are haploidy tumors, and I recommend the article by Christopher Steele about 10 years ago or so in one of the high-end journals, I can't remember what journal it is, that opens the whole complexity of undifferentiated sarcoma. We call it histologically as one tumor type, but in the future I won't be surprised if it's split, by genetics, and if especially could be clinically relevant, but we don't know it yet.
Yeah, I think it was an interesting lecture. How do you think the classifier works?
Yeah, hey, that's an excellent question, and now it depends what you feed in. Like we feed in problems, we feed everything we put there sometimes, then we don't get very good output. But if you put beautiful, let's say, fusion sarcomas, which you may be able to diagnose anyway, then it may be like 100%. But if you put it in lymphocyte-rich tumors, you get lots of calls for Langerhans histiocytosis or inflammatory myofibroblast tumor right there, although whatever they are, something like liposarcoma or anything, or lymphoma maybe.
So it sounds like it can give you comfort if it confirms the diagnosis, discomfort if it doesn't fit. But I think you show the way this works is basically there are statistical models, no? They use this clustering, so you give the machine the known diagnosis, then it looks at the proportion of different methylation, then it tries to find the ones that are higher proportion and clusters them. And then it makes a vector, like a summary number for that particular number. And then it compares your own case to that. Then it was showing that more than 0.5 causes certain class, more than 0.9 gives you a specific diagnosis. But that's a very rigid way to look at the results. Now people are trying to do this sort of thing with neural networks, where you understand even less what the machine is doing. Or with ChatGPT, they use these transformers. They use the data into small bits, then the computer finds correlations in certain way, and then it finds the answer. But the advantage of this method is that they learn from experience. So in the case that you had a lot of lymphocytes, maybe we can introduce it as a case with a lot of lymphocytes. And then over time, this will become more precise. So this advancement of the technical aspect of pathology and also the informatics, which is probably going to change things over time.
And in about 1 year, I think we should have version 2, which has over 100 entities. Now there are only 60.
Yeah, that also sounds very impressive, but when you do these multivariate models, you need a lot of cases for validation. The general rule is that you need 10 to 1. So you have, I don't know, you're looking at 10,000 genes, you need like 100,000 cases to give you validated. So these things are not so simple like they appear. But over time, I think it's likely that there will be a lot of progress.
Mariam?
I've got more comments. Another question. We don't have that impressive numbers you have. We are going close to 700 maybe cases with methylation profile. And we do brain tumors here, so I can compare. Brain classifier is excellent. It works in challenging cases pretty well. For sarcomas, it's not that good right now, but it will become much better when more entities are included in newer versions. But right now, the best indications for methylation profiling for either nose or tissue lesion is if you think about undifferentiated, differentiated, transdifferentiated melanoma, because it works almost perfect for these. Because otherwise, other soft tissue tumors you are able to solve by morphology, immunohistochemistry, FISH, sometimes DNA profiling, and it's not that helpful for sarcoma cases, in my eyes. At least these days, yeah.